handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Good day, top-notch Genesis students. My name is JL Santos and I will be your pathology teacher for today. The outline given to me was basic pathologies, ranging from cellular responses to stress, inflammation and repair, hemodynamic disorders, genetic disorders, diseases of the immune system, and neoplasia. Our first chapter is cellular responses to stress. Our first topic is necrosis versus apoptosis. So how do we differentiate the two? Necrosis is pathologic cell death versus apoptosis, which is programmed cell death. So in necrosis, nagkakaroon ng enlargement or swelling of the cell. The nucleus undergoes pycnosis, karyorrhexis, and karyolysis. So ano ibig sabihin nito? Yung pycnosis, parang nagko-condense or nagpipinchnosis yung nucleus. Karyorrhexis, ibig sabihin nun nasisira or nababasag yung nucleus. And lysis, meaning nawawala na talaga yung nucleus. The plasma membrane is disrupted, and because of this, enzymatic digestion, nag-leak out siya of the cell. So since nagkakaroon ng cellular contents outside of the plasma membrane, nagkakaroon ng adjacent inflammation. And this is always pathologic. Versus apoptosis naman, as I said earlier, programmed cell death siya. So imbes na nagsiswell, nagsishrink yung cell, tapos yung nucleus, nagkakaroon siya ng fragmentation into nucleosome-sized fragments. The plasma membrane is intact, and because of this, there is no adjacent inflammation. It is often physiologic, but sometimes it will be pathologic, as I will discuss later. Okay, so this is a visual representation of necrosis versus apoptosis. In necrosis, you have a reversible injury and sometimes nagkakaroon ng recovery of the cell. However, kapag nagkakaroon ng progressive or irreversible injury, nadidisrupt na yung cellular membrane, also nasisira yung mga organelles, and nagli-leak yung mga cellular contents. So nagkakaroon ng adjacent inflammation like these neutrophils. And this is necrosis. And then you have your apoptosis. So there is a condensation of the chromatin, and you have your membrane blebs. And as mentioned earlier, you have your cellular fragmentation. So nagkakaroon sila ng mga apoptotic bodies containing the organelles, which is to be phagocytosed by macrophages. So walang adjacent inflammation. Now we go to cellular adaptations, the first one being hypertrophy. Hypertrophy means an increase in cell size. So to remember this, mag-draw kayo ng trophy, tapos isipin nyo lang, malaki na trophy, parang first place prize. So, nagkakaroon lang ng increase in cell size. So, the stimulus usually is increased workload and hormonal stimulation, such as in pregnancy. So, in this picture, you have a non-gravid uterus contrasted with a gravid uterus. So, sobrang laki ng gravid uterus. Tapos, if you look at them under the microscope, this one naman is the gravid and this one is the non-gravid uterus. So, compare nyo sila, yung mga smooth muscles or yung spindle cells, sobrang liit, di ba, dito sa non-gravid uterus or normal size. Dito naman sa gravid uterus, swole sila, di ba? So, yan, napaka-wide naman ng mga smooth muscle cells. So, the mechanism here is increased protein synthesis. Physiologic, again, uterus in pregnancy and muscle in bodybuilding kapag nagiging swole tayo. Pathologic naman, pwede mangyari yung hypertrophy sa pathology, such as in left ventricular hypertrophy in hypertension. Next, you have hyperplasia. So hyperplasia meaning an increase in cell number. So contrast that with hypertrophy, which is an increase in cell size, di ba? So the stimulus is usually hormonal and there is a compensatory response. So the mechanism is growth factor-driven proliferation of mature cells or increased output of new cells from tissue cells, stem cells. So, for example, this is endometrial hyperplasia. Makikita nyo na these glands, so eto mga to, yan, 1, 2, yan, 3, and scattered across sila. Tapos sobrang liit na ng stroma, sobrang konti, sobrang scant ng stroma, and sobrang crowded ng glands because there is hyperplasia. Physiologic examples of hyperplasia include pubertal breast changes and liver regeneration after liver surgery, and you have your pathologic, which is endometrial hyperplasia. So as I said earlier, so ayan. Next, we have atrophy, which is a decrease in cell size and number. So if you look at this picture, this is a normal brain, and this is a senile atrophy of the brain. So makikita nyo yung mga spaces in between the gyri, which is called the sulci. Dito, sobrang liit nila, parang pencil lang. Pero dito nakikita nyo na sobrang lalaki na ng spaces because the cell mass or the gray matter, nawawala na sila, nag-atrophy na sila. So the stimulus here is usually decreased workload, denervation, ischemia, malnutrition, loss of endocrine stimulation, and pressure. So isipin na lang, if you're not using that body part as much, nagkaka-atrophy siya because your body is telling you, oh, you don't need this anymore. So lilit na lang siya or magdi-disappear na lang siya. The mechanism usually is decreased protein synthesis, increased protein degradation, and autophagy. So the examples here are embryonal. So for example, yung fingers natin. So usually, nag-start out siya as like one big hand pad. And then, nagkakaroon ng atrophy of the spaces in between the fingers. So nagkakaroon tayo ng fingers, no? Pathologic naman, again, the senile atrophy of the brain and cancer cachexia. Lastly, we have metaplasia. The definition here being differentiated cell type replaced by another cell. The stimulus here being stress. So the mechanism is reprogramming of the stem cells. So for example, smoking. So the smoking changes the bronchial epithelium na normally na columnar epithelium, biglang magkakaroon ng metaplasia into squamous. And then we also have Barrett esophagus naman, one of the more prominent or popular examples of metaplasia in which the squamous cells of the esophagus nagiging columnar naman. So baliktad sila no sa smoking. Okay? Next, we have our patterns of necrosis. So let's start with coagulative. So, the coagulative, nagkakaroon siya ng preservation of the architecture of the dead tissues. So, usually, nakikita natin siya sa infarct of all organs except the brain, which undergoes liquefactive necrosis. So, this is a coagulative necrosis of the spleen. So, this part of the spleen na infarct siya. So, naging yellow na siya on gross autopsy. And when you look at it under the microscope, pakikita nyo na ang daming inflammatory infiltrates, so mga neutrophils, lymphocytes, and then this part of the organ is already dead. So nakikita nyo na parang amorphous pink materials, that's necrosis na. So nagli-leak out na yung mga contents ng cells, tapos nagsiswell na sila. Next, we have liquefactive necrosis. So it is the digestion of the cellular architecture leading to liquid viscous mass known as pus. So nakikita natin siya in ischemic necrosis of the brain. So for example, nagkaroon ng stroke yung patient, and then ito yung area na na-stroke. So syempre nawalan siya ng blood supply, namatay yung cells ng brain, tapos it undergo liquefactive necrosis. So this part, parang this was filled with liquid, na ngayong inautopsy na, meron na siyang parang hole. Next, we have gangrenous necrosis. So usually nakikita natin siya in patients with diabetic foot, diba? So dry gangrene is an ischemic to coagulative necrosis of the extremities, seen here. Next, if na-superimpose naman siya with bacterial infection, that is called wet gangrene. Next, we have uricatious necrosis seen in TB, or usually nakikita natin siya sa TB. So it is cheese-like friable white area of necrosis seen in tuberculous infection. So, una nagkakaroon muna ng granuloma formation and then nare-replace siya with caseous necrosis such as in secondary TB, like this. Diba? Nakikita siya sa mga apex of the lungs. Next, we have our fat necrosis. So, fatty acids from triglyceride breakdown combined with calcium ions to form soap or called saponification. So, ang nakikita sa histologic examination, meron siyang shadowy outline of necrotic cells, fat cells, with basophilic calcium deposits. So, nakikita siya sa pancreatitis leakage because we all know that the pancreas contains digestive enzymes, diba? So, kapag nag-leak out sa pancreas yun and comes in contact with fat or like the omentum, for example, magkakaroon ng fat necrosis. So, ito may mga foci of calcium deposits, diba? Yeah. Lastly, we have fibrinoid necrosis. So this occurs when complexes of antigens and antibodies or immune complexes are deposited in the walls of arteries. So as we know, when these immune complexes are deposited in the walls of arteries, magpaproduce sila ng inflammation. Tapos kapag chronic na tong inflammation na to, the cells will necrose. So it results into bright pink amorphous densities termed fibrinoid or fibrin-like. So it is seen in immunologically mediated vasculitis. Can you give examples? So, it's like cataclyaso-arteritis, giant cell arteritis, and yung mga Berger disease. And lastly, we have intracellular accumulations. So first, we have atherosclerosis and xanthomas, which are intracellular accumulations of cholesterol. So for example, atherosclerosis of the arteries. So this one is carotid artery. So as you can see here, may bifurcation. Tapos, nag-accumulate siya dun sa bifurcation. And then we have xanthomas, seen in familial hypercholesterolemia. So nakikita natin siya sa mga eyelids as mga yellow masses, yellow soft masses. We also have intracellular accumulations of protein and glycogen. So for example, yung mga glycogen storage diseases. So pag nagkaroon tayo ng section of the liver, makikita natin itong mga intracellular accumulations of glycogen seen in periodic acid shift stain. And then we also have pigments. So first we have carbon. So nakikita natin siya sa mga coal workers pneumoconiosis. So makikita nyo lang siya as black masses in the lungs or in the alveoli. You also have lipofuscin, which is wear and tear pigment. So nakikita nyo siya para siyang gold or copper accumulations. So ito, this is the heart. Tapos kapag as we grow older, nakikita natin na dumadami ang lipofuscin pigments. And then lastly, we have hemosiderin. So for example, nagkakaroon ng iron overload sa katawan natin. When you take a section of the organ, so kunwari mga liver, ganon, magkakaroon siya ng super daming hemosiderin seen in this Prussian blue stain. So it stains iron kasi. So kita nyo, sobrang daming blue, which is an indication of iron overload. Our next chapter is inflammation and repair. First, let's go to the cardinal signs of inflammation. Di ba nung second year, tinuruan tayo nung 5 catchy words that are the signs of inflammation, namely, rubor, calor, dolor, tumor, and functionalisa. So yung rubor, parang ruby, redness, di ba? Calor, parang init, warmth. And then you have dolor, which is pain. And then tumor, as in, parang tumor, swell. Tapos, functionalisa, meaning loss of function. So, for example, ito, parang cellulitis at the top of the leg, and then you have redness. Tapos, kapag tinouch niya yan, warm to touch sila, and then the patient will complain of pain, and then as you can see, elevated siya, which is swelling. And then sometimes, nagkakaroon ng loss of function. So, the general steps of inflammation. First is recognition of the injurious agent. So, the stimuli for inflammation can range from microbes to necrotic tissue, and then nagkakaroon ng recruitment of leukocytes because these leukocytes recognize these stimuli as foreign or parang pathologic, so pupunta sila dun sa area. And then, nagkakaroon ng removal of the agent because these white blood cells, mga macrophage, dendritic cells, mast cells, mag-release sila ng mga substances that will kill the agent, okay, or remove it. Okay, so there is also regulation of the response because ayaw mo naman yung area na yun na maging inflamed forever, di ba? So magkakaroon ng release of anti-inflammatory interleukins, di ba? And then finally, you have your resolution and repair. So pwedeng for example, pag nasugatan kayo, it will be in the form of a scar. Okay, so we have acute and chronic inflammation. So, unahin natin yung acute inflammation. So, yung components niya, first magkakaroon ng dilation of small vessels. So, that will produce the erythema or the rubor. Next, we have increased microvascular permeability because of the release of histamines or other mediators from the neutrophils and magkakaroon ng emigration of the leukocytes and their activation. So, first, magkakaroon ng contraction of the endothelium. Kapag nag-contract yung mga endothelium, magpo-produce siya ng mga spaces in between. Bakit? Para saan to? It's because the neutrophils want to go to the site of the injury. So, from the blood vessel, lalabas sila para makapunta sila dun sa site of the injury. Okay, so the process of inflammation. So, first magkakaroon ng recruitment of leukocytes. So, isipin mo na neutrophil ka and then sabihin sa'yo ng body, oy, mayroong sugat. You have to go to this site, sa finger. Okay, so for example, nandito ka pa sa may heart, ganon. So, pupunta ka dun sa arm and then yung vessel doon, magkakaroon ng margination muna or pupunta ka doon sa blood vessel wall. And then mag-roll ka to the site and then magkakaroon ng adhesion doon sa endothelium. And then diapedesis is going through the endothelium and then chemotaxis or going to the site of the injury. And next, you have the removal of the agent. So, since na-activate yung mga leukocytes ng reactive oxygen species and nitric oxide, mag-release sila ng mga lysosomal enzymes and neutrophil extracellular traps to kill the microbes. And then, you have the regulation of the response because again, you don't want that area to be inflamed forever. Tapos ang anti-inflammatory cytokines ay TGF-beta and IL-10. Okay, so we have the mediators of inflammation. So first, you have your vasoactive amines, the histamine and serotonin, then the arachidonic acid metabolites, cytokines and chemokines, and your complement system. Pero unahin natin si cytokines and chemokines. So, ang alalahanin nating parang triad of cytokines and chemokines for inflammation is TNF-alpha, so TNF, IL-1, and IL-6. So silang tatlo palagi yung parang magkasama kapag nagkakaroon ng inflammation. So ayan, TNF-alpha and IL-1 will activate leukocytes, will activate T cells, tapos they in turn they will activate other cell types. And then you have your systemic protective effects. So, di ba usually kapag nagkakaroon tayo ng infection, nagkakaroon ng fever, it's because these cytokines will go to the hypothalamus and increase the temperature or regulatory temperature set point para magkaroon ng fever tayo. And then, they will also stimulate the liver to produce acute phase proteins and the bone marrow to produce more leukocytes. And then, ito naman sa systemic pathologic effects, magkakaroon ng low output yung heart, increased permeability, and insulin resistance. Next, we have our arachidonic acid metabolites. So, they all come from cell membrane phospholipids. So, pag na-activate sila ng phospholipase, magiging arachidonic acid sila. And they can go to either one or two pathways, the cyclooxygenase pathway or the lipoxygenase pathway. So, yung mga cyclooxygenase, they will produce prostacyclins, thromboxane, and prostaglandins. So, ang prostacyclin and prostaglandins, they will produce vasodilation. However, yung thromboxane A2 naman, so it affects platelets and prothrombotic siya, so it causes vasoconstriction and platelet aggregation. Next naman, yung lipoxygenase pathway will produce leukotrienes and lipoxins. So, saan natin naalala yung leukotrienes? Diba? Bronchospasm and asthma. Kaya sometimes, bibigay tayo ng leukotriene receptor inhibitors sa asthma, which are zafirlocas and montelukast. Okay? Next, we have your complement system. So, yung complement, they are a group of proteins produced by the liver and inflammatory mediators din sila. So, there are three pathways that can activate these complements, namely the alternative pathway, the classical pathway, and lectin pathway. So, yung alternative pathway, nare-recognize niya yung mga PAMPs or protein-associated microbial products from microbes, antibodies sa classical pathway, and mannose-binding lectin sa lectin pathway. And then they converge into a similar pathway which cleaves C3b deposited on microbes. Tapos, yung mga effector functions niya, first is inflammation using C5a and C3a. They are also called anaphylatoxins. C3b for phagocytosis or the MAC or the lysis of the microbe. MAC uses C6 to C9. So, mga late complements yung mga yan. Kapag nagkakaroon tayo ng deficiency in C6 to C9, hindi makaka-form ng MAC. Tapos, magkakaroon ng susceptibility to Neisseria infections. Neisseria. Okay? Next, you have your morphologic patterns of acute inflammation. First is serous, which is an exudation of cell-poor fluid. So, in other words, parang tubig lang siya or plasma. Seen in this blister, so for example, ito yung epithelium, and then this is the lamina propria. In between that, there is fluid. So parang, di ba ang mga blisters, parang mayroon lang siyang water sa ilalim ng skin? That's it. Next, you have your fibrinose, which is an exudation of fibrin in the extracellular fluid. So for example, in fibrinous pericarditis, as you can see here, mayroong fibrinous depositions in the pericardium. So, ayun, parang kapag inauscultate mo yan, it sounds like or hair being rustled. Kasi nga, ang daming fibrin, di ba? Next, you have your purulent or basically pus or nana. So, it is an exudation consisting of neutrophils and necrotic debris. So, in this organ, makikita nyo, mayroong mga islands of pus. So, itong mga white na to, yan, pus yan. Pero usually pus, pag nakikita natin is color green, di ba? So next, you have your ulcers, which is an excavation of the surface of an organ or tissue due to shedding of inflamed and necrotic tissue. So, for example, etong ulcer na to, nakikita natin sa stomach, like in peptic ulcer disease. So, ang ginagawa ng Helicobacter pylori, sinisira niya yung epithelium ng stomach. Kaya nag-leave siya ng hole. And this could perforate and cause bleeding when it ruptures a vessel. Next, you have your chronic inflammation. So this is a response or prolonged duration in which inflammation tissue injury, and attempts at repair coexist. Its causes include persistent infection, hypersensitivity or autoimmune diseases, and prolonged exposure to potentially toxic agents. The principal cells involved are macrophages and lymphocytes, which in contrast to acute inflammation, neutrophils. So for example, in this foci here, punong-puno yan ng lymphocytes. So, lymphocytes, di ba, mononuclear sila. So, yan. So, hindi bilobed yung nuclei nila, circle lang. And then, meron kang mga areas of fibrin deposition, and then meron din mga areas of necrosis. So, ito, alveoli ito, tapos parang nakikita nyo, di ba, sirang-sira na sila. And ang daming mga lymphocytes scattered across. Next, we have granulomatous inflammation, which is hallmarked by granuloma. So, it is a collection of activated macrophages, often with peripheral T lymphocytes, sometimes associated with central necrosis. Diba? As we said earlier, parang yung caseous necrosis sa mga tubercles. Okay? So, yung activated macrophages, magiging epithelioid cells sila, which is the hallmark of granulomatous inflammation, or giant cells. Nakikita to when, for example, foreign bodies are left inside the body or immune if tuberculosis. So makikita nyo, these are called Langerhans giant cells. So nakikita siya sa tuberculosis. So basically, di ba, sobrang dami niya nuclei, tapos malaki siyang cells. Kaya giant cell. Again, remember, Langerhans giant cell, tuberculosis. Next, you have your tissue repair. So ano nangyayari sa tissue repair? First, magkakaroon ng angiogenesis. So, you need that because you need the blood to reach the affected area para mag-migrate dun yung mga neutrophils, para mag-start yung process of inflammation, and eventually mag-heal siya. So, it is mediated by VEGF or vascular endothelial growth factor. Next, you have magkakaroon ng granulation tissue, which is the hallmark of repair. So, pag for example, naglilinis kayo ng mga pressure ulcers, tapos nakikita nyo parang meron na doon granulation tissue, which is parang bright red, parang bumpy siya. That is granulation tissue, and that means gumagaling na yung sugat. And then, you have remodeling of scars. So, syempre, after ng mga polymorphonuclear lymphocytes, kapag nawala na yung microbe, wala na yung offending agent, pupunta na doon yung mga fibroblasts, tapos maglalabas na sila ng collagen. Pero sometimes, nagkakaroon ng abnormalities like keloid and hypertrophic scars. Ang difference lang nila being the keloid will go beyond the border of the original wound. And then you also have wound contraction, which is mediated by myofibroblasts. So for example, if you leave a wound using secondary intention, so hindi nyo siya isusuture, magkakaroon ng myofibroblasts para i-contract yung wound, para mag-oppose yung edges a little bit. So parang lalapit sila towards each other. And that's it for this chapter. Our third chapter is hemodynamic disorder. Our first topic here is edema and effusion. So you have four main forces that will determine if magkakaroon ng edema or effusion. So first, you have increased hydrostatic pressure. So for example, in the case of heart failure, for example, this is a pulmonary capillary. Kapag hindi na gumagana yung left ventricle, magbaback up lahat ng blood doon sa lungs, di ba? Na sobrang taas ng pressure dito, lalabas siya, mag-extravasate siya. Tapos ano yung space dito? Di ba yung mga alveoli? So, magkakaroon ng pulmonary edema or pulmonary effusion. Next, you have your decreased oncotic pressure. So, in cases of nephrotic syndrome and liver cirrhosis, so di ba nawawala ang albumin? So, our body loses albumin in nephrotic syndrome or doesn't produce albumin in liver cirrhosis. So, because of that, walang anything that will keep the blood inside the capillary. So, mag-extravasate siya. So, nagkakaroon ng ascites, nagkakaroon ng pulmonary effusion, nagkakaroon ng edema sa extremities kapag meron tayong ganitong conditions, nephrotic syndrome and liver cirrhosis. We also have increased vascular permeability in the case of burns and infections, and lymphatic obstruction such as masses or post-surgery. And also, like in the case of lymphatic filariasis, they obstruct the lymphatics. Kaya, since the lymphatics are the ones that will recycle the fluid back, interstitial fluid back to the heart. So, kapag wala tong recycling system na to, pag sira siya, edi magsistay yung fluid in the interstitium. Next, we will differentiate transudate versus exudate. So, yung transudate, ang pag-alala ko sa kanya is clear fluid and exudate is basically pus. So yung pathophysiology ng transudate, it is an abnormality in starting forces. So let's take heart failure for example. So yun nga, nagkakaroon ng mataas na pressure in the pulmonary capillaries kaya nagkakaroon ng pulmonary edema. And then you have normal vascular permeability. Ibig sabihin nun, it's just because mataas ang pressure nung sa capillary pero the endothelium is still normal. The plasma protein leak here is absent and the protein content of the fluid is low because nandun lang naman sila sa loob ng capillary, ang lumalabas lang is the fluid, kaya clear. Siyempre, since clear siya, ang low ang specific gravity niya and walang fibrin and inflammatory cells. Next, you have your exudate. So, di ba, sa inflammation, there is increased vascular permeability. There is a present protein leak and high protein content of the fluid. Since nagko-contract yung endothelium, kaya maglumabas ng protein, di ba? So, because of that, mataas ang specific gravity, may fibrin, and there is inflammatory cells. So, an example of this is pneumonia. So, sometimes organs can get congested, like in the lung and the liver. So, lung, naka-congest siya in left, heart failure, ang liver naman naka-congest siya in right. So kapag nagkakaroon ng acute lung congestion, there is engorgement of the alveolar capillaries. So for example, in a heart attack, so acute failure of the heart yun, di ba? The left side of the heart. And then there is alveolar septal edema and focal intraalveolar hemorrhage. Contrast this with chronic, so ito yun. There is thickened and fibrotic septa, ito yun. And then there is hemosiderin-laden macrophages or what you call heart failure cells. So sila tong mga brown macrophages over here. And then you have naman, sa liver naman, so for example, in cases of acute liver congestion such as in pulmonary embolism, merong distended central vein and sinusoids, centrilobular ischemic necrosis, and periportal fatty change. Contrast this naman with chronic liver failure. So for example, meron ng isenmengerization, nagkakaroon na rin ng right-sided heart failure in chronic heart failure patients. So yung centrilobular regions are ghostly red-brown and slightly depressed, contrasted with a tan surface or what we call nutmeg liver. So when you look at nutmeg, parang ganyan din sila, brown, tapos meron din mga red-brown spots, di ba? And then you have centrilobular hemorrhage and variable degrees of hepatocyte dropout and necrosis. So ito yung hemorrhage, ito yung centrilobular hemorrhage. Tapos meron na rin siyang necrosis, di ba? Parang pink na siya, amorphous pink, tapos meron na rin mga lymphocytes dyan. Okay? Next, we have hemostasis. So first, you have arteriolar vasoconstriction, primary hemostasis, secondary hemostasis, and clot stabilization and resorption. So let's take a simple sugat for example. Una mangyayari dyan, magkakaroon ng reflex neurogenic mechanisms and endothelin. Tapos magkakaroon ng arteriolar vasoconstriction because you don't want that sugat to bleed forever, di ba? So magkakaroon ng vasoconstriction. And the outcome here is transient decrease in blood flow. Yung primary hemostasis naman, since nagkaroon ng exposure to subendothelial extracellular matrix, magkakaroon ng platelet adhesion and activation of the extrinsic pathway. So, magkakaroon ng aggregation which forms the primary hemostatic plug. Next naman, yung factor 12 and exposure factor 7 will activate the coagulation cascade of the intrinsic pathway naman. Kasi diba, intrinsic pathway parang it will accelerate the coagulation process ng sobrang bilis, di ba? And then, magkakaroon ng fibrin formation and additional platelet aggregation forming the secondary hemostatic plug. And then, lastly, yung permanent plug, magkakaroon ng resorption by counter-regulatory mechanisms such as tissue plasminogen activator, yung TPA, and then it results in tissue repair. So, syempre, you don't want that area to be clotted forever naman, di ba? You want to restore blood flow, kaya nagkakaroon ng counter-regulatory mechanisms. So, kaya bumabalik siya sa normal. Next, you have thrombosis, which is explained by the Virchow triad. So, for example, let's take a patient with chronic heart failure. So, for example, ito yung left side ng heart niya. So, ito yung left atrium, left ventricle, and then your aorta. Okay? So, for example, nagkakaroon ka na ng long-standing hypertension. The left ventricle, di ba nagkakaroon siya ng hypertrophy? And because of that, nagkakaroon din ng backup ng blood. Nagba-backup din yung blood because long-standing hypertension na, di ba? So, kapag lumaki na yung left ventricle, sometimes yung left atrium din, lumalaki na siya. And since lumalaki na yung left atrium, yung blood flow dito sa atrium na to, nagiging turbulent na siya. So, yun na yun. This is the first component. So, abnormal blood flow. So, since turbulent na yung blood flow niya, nasisira niya yung endothelium. Because, di ba, the more turbulent blood flow is, the more destructive it can be to the endothelium. So, nagkakaroon ng endothelial injury. And as we all know, endothelium is usually has anticoagulant properties. Pag nagkaroon naman ng endothelial injury, nagiging procoagulant siya. So, magkakaroon ng hypercoagulability. So, these three, in combination with each other, magfo-form ng thrombosis, which can cause embolism, which I will discuss next. So, major types of embolism, so pulmonary and systemic thromboembolism. So, yung pulmonary embolism naman, the most common source is deep venous thrombosis. So, for example, yung mga patients na may hypercoagulable state, tapos they remain immobilized for so long, nagkakaroon sila ng deep venous thrombosis. Tapos sometimes this can throw and form pulmonary embolism. So, yung mga malalaki like yung saddle embolus as seen here, they can cause sudden death. So, clinical findings, the majority are actually clinically silent. However, nagkakaroon ng sudden death dun sa mga malalaki. Pulmonary hemorrhage due to dual blood supply and acute cor pulmonale or right-sided heart failure. You have your systemic thromboembolism naman, which 80% is mural thrombi. So, for example nga, yung kanina na sinabi ko sa heart, and then yung size of involvement niya, usually lower extremities. But sometimes, in a minority, nag-throw siya to the brain, forming stroke. Okay? And then, yung clinical findings naman niya, clinically apparent sometimes due to symptoms referable to end organ ischemia, such as stroke nga, so in the brain. Other forms of embolism include fat and marrow embolism, which is nakikita sa mga long bone fractures. So for example, meron kang patient na or kakagaling lang sa orthosurgery, tapos nag-complain siya of difficulty breathing, entertain kayo ng fat embolism. So it produces pulmonary insufficiency and neurologic symptoms. So ang findings niyan is fat globules in pulmonary vasculature. So yan, fat parang, di ba, adipose tissue. Next, you have your amniotic fluid embolism. So, sometimes in mothers who are postpartum who develop sudden dyspneas, magiging cyanotic sila, shock, magsiseize sila, and then magkakaroon ng coma or DIC, it is because of amniotic fluid embolism. So, ang makikita sa findings niya is fetal skin, lanugo, hair, vernix caseosa, mucin, and pulmonary vasculature. So, yan, di ba, mga fetal squamous cells yan in the pulmonary vasculature. And lastly, you have air embolism. So, nangyayari siya usually in divers who did rapid ascent who complain of joint pains and respiratory of insufficiency. Yung joint pains, tawag sa kanya bends. Isipin nyo parang binebend nyo yung arms nyo. And then yung chokes naman, yun yung respiratory insufficiency. So, parang choke. Parang hindi kayo nakakahinga. So, Caisson disease naman, this happens kapag nagkakaroon ng ischemic necrosis of the femoral head, tibia, and humerus. Next, we have your infarcts. So, there is red infarct and white infarct. Yung red infarct, nangyayari siya in organs with dual blood supply, such as the lungs. So, right here. So, kita nyo na dark siya, red talaga. And then, this is usually because of venous occlusion. Tapos, makikita siya in loose spongy tissues, and then tissues previously congested or reperfusion of a site. Contrast this with white infarct, so kita siya in solid organs with end arterial circulation, such as the heart, spleen, or kidney. So this is a spleen. So merong part sa kanya na namatay na. So ito yon. This is a white infarct. So since, di ba, isa lang ang blood supply to the spleen, which is the splenic artery, magiging white infarct na siya. So yung growth niya, so like in this picture, it's a wedge shape with occluded vessel at the apex and periphery of organ at the base. So, yung microscopic niya is ischemic coagulative necrosis, again, except in the brain, which undergoes liquefactive necrosis, and most are ultimately replaced by scar tissue. Except in septic infarcts, magiging abscess sila. Lastly, for this chapter, we have shock. So, shock is a state in which diminished cardiac output or effective circulating blood volume impairs tissue perfusion and leads to cellular hypoxia. So, yun yung keyword dito, guys. So, ineffective circulating volume, that will lead to organ damage. So, yung changes generally reversible if patient survives except in neurons and myocytes. So, yung mga stroke and MI. So, first we have cardiogenic shock. So, nangyayari siya in the setting of myocardial infarction, arrhythmia, cardiac tamponade, or pulmonary embolism. So basically, there is heart failure, acute heart failure. So there's a failure of the myocardial pump resulting from intrinsic myocardial damage and extrinsic compression or obstruction to outflow. So, ang clinical picture niya is yung preload is increased because hindi ma-pump out nung heart yung blood, the cardiac output is subsequently decreased, and systemic vascular resistance is increased as a compensatory mechanism. Next, you have your hypovolemic shock. So, usually, nakikita natin siya in states of fluid loss, such as hemorrhage, vomiting, diarrhea, and burns. So, yung mechanism niya is inadequate blood or plasma volume, kaya hindi na, parang hindi na nakakahinga yung mga organs. So, yung preload decreased, cardiac output decreased, and SVR increased as a compensatory mechanism. Next, you have your septic shock. So, in overwhelming microbial infection, superantigens, trauma, burns, and pancreatitis, so nagkakaroon ng widespread activation of cytokine cascades. And as we all know, kanina, di ba, peripheral cytokines or inflammatory mediators will cause peripheral vasodilation and pooling of blood dun sa extravascular space. And sometimes nagkakaroon din ng endothelial activation and injury leading to disseminated intravascular coagulation, leading to further blockage of the arteries and capillaries that will lead to organ damage. So yung preload dito is decreased, cardiac output is increased, and SVR is decreased. Next, you have your neurogenic shock. So nagkakaroon siya in patients with spinal cord injury. So there is loss of vascular tone and peripheral pooling of the blood since the blood vessels cannot maintain a sympathetic tone. Next, we have anaphylactic shock, which is an IgE-mediated hypersensitivity. So its main mechanism is histamine. So for example, there's a kid with food allergies. For example, this kid allergic to peanut. Bigla siya nakakain sa salad, tas hindi niya alam. Magkakaroon ng widespread release of histamine, producing systemic vasodilation and increased vascular permeability. So kapag gano'n na, kapag sobrang lala na, pwede mag-go into shock yung child. So, ang pressor of choice natin for anaphylactic shock is epinephrine. Meanwhile, sa septic shock naman, norepinephrine. And then, sa cardiogenic shock is dobutamine. Okay? So, that is all for this chapter. Our fourth chapter is genetic disorders. So let's go through all the patterns of inheritance. So first, we have autosomal dominant disorders. In this type of inheritance, one dominant allele is enough to produce the phenotype. So usually, the defect is key structural proteins or receptors. So if you see the genogram of patients with autosomal dominant disorders, so sila yung mga naka-orange, it does not skip a generation. So lahat ng generations affected, tapos it equally affects both males and females. So, for example, you have a parent with a heterozygous genotype. So, ina-express niya yung disorder because it is autosomal dominant nga, di ba? And merong normal parent. So, kapag pinag-cross mo sila, 50% of the offspring will develop this phenotype. So, an example here is Marfan syndrome. So, it is a disorder of connective tissues manifesting principally in changes in the skeleton, eyes, and cardiovascular system. So, it is a defect in the fibrillin-1 gene. Tapos, yung phenotype nila, tall, long extremities, outward and upward subluxation of lens. Meron din silang mitral valve prolapse sa heart or aortic, prone sila sa aortic dissection. Next, you have Ehlers-Danlos, which is a defect naman in fibrillar collagen. So, they manifest as hyperextensible skin, hypermobile joints, meron din silang poor wound healing, rupture of arteries, corneal rupture, and retinal detachment. Next pattern of inheritance is autosomal recessive disorders. So, two recessive alleles are required to produce this phenotype. So, in a cross of heterozygous parents, so carrier sila pareho. So, ibig sabihin na they don't really express the disorder, pero carrier sila ng gene. So, 25% of their offspring will express the trait. So, usually complete penetrant siya and early onset. Tapos, metabolic disorders usually ang autosomal recessive. For example, sphingolipidosis. So first is Tay-Sachs disease. So ang defect na to is the alpha unit of hexosaminidase A producing an accumulation of GM2 ganglioside found in neurons and the retina. So makikita natin dun sa slide niya, balloon neurons with cytoplasmic vacuoles with ganglioside kasi yun nga yung accumulated. And sa retina naman, ganglion cells distended by ganglioside vacuoles and cherry red spot in the retina. For sulfatidosis naman, first you have Niemann-Pick. So parang Tay-Sachs, meron din siyang cherry red spot in the retina. However, ang difference nila, Niemann-Pick has hepatosplenomegaly. So yung defect nito is sphingomyelinase, leading to an accumulation of sphingomyelin. Tapos yung sa slides, may makikita kayong mga foam cells or lipid-laden macrophages. So swollen macrophages siya na mukhang foam. Next, you have your Gaucher, which is the most common lysosomal storage disorder. Ang defect niya is glucocerebrosidase. Yun yung deficient sa kanya, leading to an accumulation of beta-glucosidase. So, meron naman siya mga Gaucher cells, which looks like crumpled tissue paper. So, yan. Tapos, ito mukhang crumpled. Okay? Next, we have X-linked recessive. Usually naman, males express this phenotype because they only have one X, di ba? So, kapag nakuha nila yung defective X na yon, meron na sila ng phenotype, i-express na nila. If the females have expressed the phenotype, it's because of random inactivation of the other X chromosome. So, since females have two X chromosomes, and for example, ito yung defective, they have one to back it up. So, usually carriers lang sila. However, kung inactivated din yung normal X, tapos ito lang na natitirang X, edi ibig sabihin nun, ma-express nila yung phenotype. So, affected males do not transmit the disease to their sons, but all of their daughters are carriers. So, for example, ito, mayroong affected male. So, since binibigay niya lang yung Y niya dun sa mga sons niya, normal sila. However, lahat ng mga daughters niya ay carriers. Okay? Pero kapag ang female naman, ang carrier, so ito, yan, carrier siya of the affected X, yung 25% of their 50% of their daughters will be carriers and 50% of their sons will express. Okay? Examples are hemophilia, G6PD, Fragile X, and Lesch-Nyhan syndrome. Okay, next we have your X-linked dominant disorder. So, a heterozygous female paired with a normal male, so 50% of their sons and 50% of their daughters will express it. However, kapag affected naman yung male and normal female, since yung X niya, ibibigay niya sa lahat ng daughters niya, but none of his sons, yung lahat ng males, normal. Pero lahat ng daughters niya, ma-affect. So examples here ay Alport syndrome and vitamin-resistant rickets. Next, we have your disorders of autosomes. So trisomy 21 Downs, 18 Edward, and trisomy 13 Patau. So first, you have your Downs, which is the most common cause of mental retardation. Tapos yung usual features niya, yung epicanthic folds, simian crease, and meron siyang usually meron siyang heart defects or endocardial cushion defects. Yung Edward and Patau naman, both of them have rocker bottom feet. However, si Edward syndrome, meron siyang overlapping fingers. So, isipin na lang, Prince Edward, so parang binabless niyo yung mga people, overlapping fingers like that. And sa Patau naman, meron siyang cleft lip and palate. Next, you have your disorders of sex chromosomes. So, first is Klinefelter. So, phenotypically male sila, but they have an extra X chromosome. So, medyo feminized yung features nila. Meron silang female-type pubic hair pattern, testicular atrophy, breast development, poor beard growth, and mildly impaired IQ. Sa Turner syndrome naman, so wala silang isang X chromosome. So, they're living with 45X. So, usually, meron silang short web neck, tapos streaked ovaries. So, they are the most common cause of primary amenorrhea in females. Next, you have your trinucleotide repeat disorders. So, yung mga repeats na to, as kapag pahaba sila ng pahaba as each generation goes on, palala ng palala. So, first you have Fragile X syndrome. So, CGG. Ang pag-remember ko dyan is CGG yung X, as in parang name. CGG yung X. Tapos, meron silang long face, large ears, and macroorchidism. Next, you have your Huntington disease, which is CAG repeats. So, ang pag-alala ko lang dyan is Hunting cage, Meron silang movement disorders and dementia. Lastly, we have Friedreich ataxia, which is a repeat of GAA. Sipin na lang dito is ito, GAAGO, si Fred, and then they have slurring of speech, slow reflex, and incoordination, just like any other ataxia. Okay? And then, meron din isa is CTG, which is responsible for myotonic dystrophy. Next, we have disorders of genomic imprinting. So this happens because there is silencing of one copy of the gene from either parent during gametogenesis. So it occurs once the non-imprinted gene is deleted. So sa Prader-Willi, nagde-delete yung paternal. So Prader, father. So derived siya from, pareho silang derived from chromosome 15. Tapos yung Angelman naman, nade-delete yung maternal. So Angel, it sounds like a girl's name. Maternal, so mother. So sa Prader-Willi, ang clinical sa kanya, manifestation sa kanya is profound hyperphagia, as in hindi nasasatiate yung appetite nila, kain sila ng kain, demand sila ng demand ng food, which leads to obesity and hypogonadism. Meron din daw silang almond-shaped eyes. Next, you have your Angelman syndrome, which is also called happy puppet kasi nagde-display sila ng inappropriate laughter, intellectual disability, ataxic gait, and seizure. That is all for genetic disorders. Our second to the last chapter is diseases of the immune system. First, let's go to the hypersensitivity disorders. First, we have type 1 hypersensitivity or immediate. So, like, as we all know in anaphylactic shock, diba? So, it's rapid, it occurs in previously sensitized individuals, and it has two phases. Yung immediate phase, vascular changes, and yung late phase, merong leukocytic infiltration and tissue damage due to eosinophils and IL-5. So, it is IgE-mediated. An example is anaphylaxis, bronchial asthma, allergic rhinitis, or food allergies. So, lahat ng mga diseases na nasa atopic march. Type 1 hypersensitivity sila. So, yung type 2 hypersensitivity naman, antibody-mediated. So, lahat ng mga diseases na naalala nyo that involves antibodies, type 2 hypersensitivity sila. Such as autoimmune hemolytic anemia, immune thrombocytopenic purpura. You also have your vasculitides, good pasture, which involves antibodies against type 4 collagen, which is seen in the basement membrane. Tapos you also have acute rheumatic fever, and your cellular dysfunction such as myasthenia and Graves. Diba sa Graves, merong auto-antibody that is the thyroid-stimulating immunoglobulin. So, because of that, mag-overproduce ang thyroid hormone, tapos mag-produce ng hyperthyroid symptoms. Yung myasthenia naman, meron siyang antibodies against the postsynaptic ACH receptor. So, since na hindi makabind yung ACH dun sa receptor, magkakaroon naman yung mga drooping of eyelid, etc. etc. So, yung type 3 naman, antigens and antibodies form complexes to form immune complex hypersensitivity. So, immune complex deposition in tissues and its subsequent inflammatory response, and diseases tend to be systemic, such as SLE, post-streptococcal acute glomerulonephritis, polyarteritis nodosa, and reactive arthritis. So, naalala nyo dun sa post-streptococcal acute glomerulonephritis, yung mga complexes nagde-deposit dun sa glomerulus, and then it attracts mga neutrophils and everything, so magiging hypercellular yung glomeruli, and magpaproduce ng damage, kaya nagkakaroon ng parang nephritic syndrome. Next, we have your type 4 or delayed hypersensitivity, which is T-cell mediated. So, yung CD4 mediated, yung cytokines coming from the CD4, it will induce inflammation. And yung CD8 naman, facilitates direct killing by perforins and granzymes in lysosome-like granules. So, may examples nito is yung tuberculin skin testing sa TB. Since meron ka ng preformed antibodies against TB, tapos kapag in-inject nila yung tuberculin, magkakaroon ng reaction dun sa site. You also have rheumatoid arthritis, multiple sclerosis, type 1 diabetes mellitus, which destroys the beta cells of the pancreas. So, mawawala yung insulin nila, yung inflammatory bowel disease, and psoriasis. So, let's go to the most prominent autoimmune disorder, which is lupus. So, it is a type 3 hypersensitivity reaction that affects multiple organ systems. Its hallmark is a production of autoantibodies. So, let's go through some of these. So, yung ANA is the best screening test for lupus. Yung anti-Smith naman, it's more specific for SLE but it has no correlation for disease activity. Yung anti-dsDNA naman, kapag mataas siya, it is correlated with disease activity, especially nephritis. Yung anti-histone, makikita natin siya sa drug-induced SLE, and anti-RONLA is associated with neonatal lupus and the development of congenital heart block. So if you suspect the infant to have neonatal lupus, you look for anti-RO and anti-LA para makita nyo kung magkakaroon sila ng congenital heart block. So, since lupus is a widespread disease nga, diba, it affects almost all organ systems. So, first, we have derma. So, usually, diba, may malar rash sila or yung parang butterfly rash over the malar prominences and photosensitivity. You also have discoid rash in chronic lupus erythematosus. And meron din silang sometimes alopecia, meron silang oral ulcers, and then sometimes, most of the time, they complain of joint pains. And then sometimes kakaroon din sila ng serositis in the form of pleuritis or pericarditis. They also have renal disorders such as persistent proteinuria leading to lupus nephritis. So neurologic disorders naman, sometimes seizures, they complain of psychosis, nawawalan sila ng memory, ganun-ganon, neuropathies, in the absence of offending drugs or other known causes. And then they also have a big hematologic component. So, nagkakaroon sila ng hemolytic anemia, thrombocytopenia, leukopenia, and lymphopenia. Next, you have your Sjogren's syndrome, which is an autoimmune destruction of the lacrimal and salivary glands, which produces dry eyes and dry mouth. So, yung mediators niya is anti-RO and anti-LA. The earliest histologic finding is periductal and perivascular lymphocytic infiltration. So, dun pa lang makikita mo na parang ina-attack na niya yung mga glands. Yung late findings include acinar atrophy, fibrosis, hyalinization, and replacement of parenchyma to fat. So, makikita nyo na punong-puno yung gland ng lymphocytic infiltrate, thus masisira na sila. Ayan. Tapos, in this patient, sobrang laki na nung parotid niya. No? Scleroderma naman is a disease entity wherein parang nagpa-fibrose yung entire body mo. There is a triad of chronic inflammation, widespread damage to small blood vessels, progressive fibrosis in the skin and multiple organs. So yung diffuse scleroderma naman, which is anti-SCL, meron siyang widespread skin involvement, rapid progression, and early visceral involvement. Yung limited scleroderma naman, or makikita siya kapag mayroong anti-centromere, okay? It's also called CREST syndrome because parang mnemonic na rin siya. Calcinosis, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Again, diffuse scleroderma anti-SCL and limited scleroderma anti-centromere. So we'll tackle primary immunodeficiencies. These are inherited genetic disorders that impair mechanisms of innate or humoral immunity. It is detected between 6 months and 2 years of age because less than 6 months, meron ka pang maternal antibodies and yung hallmark niya is susceptibility to recurrent infections. First, you have SCID, which is an impaired development of mature T and B lymphocytes. Usually, meron silang deficiency in ADA or adenosine deaminase deficiency. So, yung infections niya, oral candidiasis, severe diaper rash, and failure to thrive. Without stem cell transplantation, death occurs within the first year of life. Example nito is the boy in the plastic bubble. Next, you have your Bruton or X-linked agammaglobulinemia. So it is a failure of pre-B cells to differentiate into mature B cell, and as a result, there is an absence of antibodies in the blood. So as we all know, diba, ang B cells, if activated, pwede sila maging plasma cells that produce the antibodies. So mutations in a tyrosine kinase called Bruton tyrosine kinase, walang signals to mature yung B cells. So it isn't apparent until 6 months of age, again, after maternal antibodies that were transported via the placenta are depleted. Yung DiGeorge syndrome naman or thymic aplasia happens kapag nagkakaroon ng deletion of chromosomal region 22q11 and it affects the 3rd and 4th pharyngeal pouches. So as we all know, these pouches develop to become the thymus and parathyroid. At diba sa thymus, dun nagmamature yung mga T cells natin? So, kapag nagkakaroon ng deficient T-cell maturation, we are extremely vulnerable to viral, fungal, protozoal, and intracellular infections just like in AIDS. So, catch-22, Yun yung parang mnemonic for the George syndrome kasi 22 chromosomal region 22, and it stands for cardiac anomalies, abnormal facies, thymic hypoplasia, cleft palate, and hypocalcemia because the parathyroids are responsible for increasing the blood levels of calcium using parathyroid hormone or 'di ba PTH, patahasin ang calcium. Next, you have your IgA deficiency, which is the most common primary immune deficiency disease. Eh, di ba ang IgA, nakikita natin siya sa mucosal surfaces. So, magkakaroon siya ng recurrent sinopulmonary infections and diarrhea. Next, you have your Wiskott-Aldrich syndrome, which is a triad of thrombocytopenia, eczema, and vulnerability to recurrent infection. So, yung mutation niya is X-linked WASP gene. So, Wiskott-Aldrich syndrome protein gene, and the only treatment is again stem cell transplantation. So, pag nakarinig kayo ng eczema plus immunodeficiency, always think Wiskott-Aldrich. Next, you have your primary immunodeficiencies. So, hindi siya inherited, acquired siya. So, HIV is a human retrovirus belonging to the lentivirus family. So, you have two serotypes, 1 and 2, pero more common yung HIV 1 and associated with AIDS. So, yung pathogenesis niya, nagbabind yung GP120 to CD4. Tapos, meron siyang mga co-receptors called CCR5 and CXCR4. And then you have your fusion through GP41, and then yung RNA genome of the virus undergoes reverse transcription. Kaya siya retrovirus, which forms a complementary DNA or cDNA. May integrate tong cDNA into the host genome. So kapag na-translate yung yung cDNA na to kasama na dun sa genome, magpo-form pa ng more viruses. And sometimes it can activate, leading to cell death, which decreases the CD4 levels. So the natural history of HIV infection starts with the acute phase. It is when the virus enters through mucosal surfaces such as, for example, sa sex or when the mother gives birth to a baby, and infection of the memory CD4 T cells. Within 3 to 6 weeks, 40 to 90% of individuals will develop the acute HIV syndrome, which is triggered by the initial spread of the virus and host response. Yung symptoms niya parang flu, sore throat, myalgia, fever, weight loss, and fatigue. Then after nun, magiging clinically silent yung person for a while, called the latent phase, because the body produces virus-specific CD8 cytotoxic T cells that contain the virus. However, sa lymph nodes and sa spleen, mayroong continuous HIV replication and cell destruction. So even though the person is asymptomatic, bumababa yung CD4 counts nila. And then lastly, you have the AIDS. So dito nagkakaroon na ng breakdown of host self-defense, increase in plasma virus levels, and life-threatening clinical disease because of the opportunistic infections. So as we can see here, first, dun sa acute HIV syndrome, sobrang taas ng viral load niya. And then biglang bumababa ang CD4 T cells. Pero kapag, kunwari, di ba nga nagkaroon ng cytotoxic T cells specific to the virus, magpo-produce yung latent phase. So, bababa yung viral load, and then medyo steady yung CD4 T cells. However, as I said, di ba, merong continuous destruction of the CD4 T cells. And then, kapag siguro nakareach siya ng mga critical levels such as less than 200, magkakaroon na ng start of opportunistic diseases, no? And then, kapag sobrang taas na ng viral load, tas sobrang baba na ng CD4 T cells, basically wala ng immune system yung person, and they die. So, the opportunistic infections associated with AIDS or yung mga AIDS-defining illnesses, so usually nagsistart siya dito sa less than 200. Pero pag less than 500 na, meron na rin mga nagpapakitang mga diseases such as TB, HIV and Candida esophagitis, and Kaposi sarcoma. Kapag doon na sa mga less than 200, doon na lumalabas sina PCP pneumonia, cerebral toxoplasmosis, meningoencephalitis, coccidiomycosis, and cryptosporidium diarrhea. And so ito yung, this is esophageal candidiasis, this is cerebral toxoplasmosis, and then sa less than 50, you have your MAC avium complex pneumonia. So ito yun, intracellular siya, invasive pulmonary disease, histoplasmosis, and CMV retinitis. So, yan, kapag tinignan mo yung patients, AIDS patients na progressively nag-lose ng vision, tapos this is what you see on the fundoscope, think CMV retinitis. Lastly, we have neoplasia. So sa cancer epidemiology, yung incidence for male and female, always think kung ano yung parang organ specific sa kanila. So prostate for males, breast for females, yun ang highest in incidence. However, sa deaths, yung lung pa rin ang most common. So parang nag-switch lang yung places nung prostate lung, breast lung, pero third place pa rin si colon and rectum. Yung characteristics of benign and malignant neoplasias. So, three features by which most benign and malignant tumors can be distinguished is differentiation and anaplasia, local invasion, and metastasis. So, let's compare these two images. So, this is what you call well-differentiated tumor. So, it resembles its cell of origin. So, parang nag-hyperplasia lang yung cell of origin niya. However, dito naman, poorly differentiated tumor to. So, sobrang daming abnormal looking cells, di ba? So, yung nuclei nila sobrang laki, abnormal yung shape nila, mayroong abnormal mitotic spindles, abnormal yung shape ng cell itself, and then the nucleus to cytoplasmic ratio is increased. Next, you have your hallmarks of cancer. So, first is self-sufficiency in growth signals. So, meron silang growth signals that are mutated para maging palagi silang activated. Kaya grow sila ng grow, multiply sila ng multiply. An example is the RAS or the most common mutated oncogene. And then you also have insensitivity to inhibitory signals. So for example, yung RB, yung responsible for retinoblastoma, it regulates the G1S checkpoint, so growth/synthesis checkpoint. So kapag mutated to, hindi nagsistop yung cell dito sa G1S. Go lang siya ng go, synthesize lang siya ng synthesize. You also have altered cellular metabolism, which is called the Warburg metabolism. So cancer cells are use aerobic glycolysis to survive. You also have evasion of cell death by loss of P53, which is the guardian of the genome, or overexpression of BCL2, which is anti-apoptotic. Okay, you have limitless replicative potential using telomerase. So yung mga cancer cells have telomerase para sobrang dami niyang telomeres, di ba? Para hindi siya maubusan. Angiogenesis naman, mediated by VEGF. You have your invasion and metastasis using E-cadherin and matrix metalloproteinases. So, ang ginagawa ng mga to, kinikleave nila yung nasa gitna ng mga endothelium para the cancer cells can go out of the blood vessels and go into other sites. Okay? And then you have your evasion of immune surveillance using MHC1 and CD8 T cells. Next, you have chronic inflammatory states leading to cancer, such as asbestosis and silicosis, producing mesothelioma and lung carcinoma, IBD, producing colorectal cancer, pancreatitis, producing pancreatic carcinoma, GERD, producing esophageal carcinoma through, di ba yung Barrett's esophagus, as said kanina, so pre-malignant lesion yun to esophageal carcinoma. Gastric ulcers, producing malt lymphoma from H. pylori. So kapag in-eradicate mo yung H. pylori, may malaking chance din na mawala yung malt lymphoma. So it is the only lymphoma or the only cancer that can be cured by an antibiotic. You have your hepatitis leading to hepatocellular carcinoma. So hepatitis C and hepatitis B both produce it, pero mas common sa HCV. So isipin niyo lang C chronic. Okay? And then you have cervicitis leading to squamous through HPV 16 and 18. Inherited predispositions to cancer include retinoblastoma, leishmania, APC, producing familial adenomatous polyposis and colon CA. So NF1 and NF2 producing neurofibromatosis, and BRCA1 and 2 producing breast and ovarian CA. So there are viruses also that can produce cancer. So yung HPV 16 and 18 natin, producing cervical, vulvar, and penile squamous cell CA. So, as adolescents and young adults, we should get the HPV vaccine. So, H. pylori naman, it can produce malt lymphoma, EBV associated with Burkitt, nasopharyngeal CA, and primary CNS lymphoma, which is an AIDS-defining disease. HHV8 producing Kaposi sarcoma, also seen in AIDS patients. HTLV1 producing adult T-cell lymphoma, hepatitis B and C for hepatocellular carcinoma. So yung Cushing syndrome, nakikita siya sa small cell cancer of the lung or pancreatic CA. Tapos syempre nag-mediate siya using ACTH. You have symptom of inappropriate ADH secretion, again from small cell CA, hypercalcemia from squamous cell CA of the lung or breast CA, producing PTH-related peptide. You also have myasthenia from thymomas or bronchogenic carcinomas, and acanthosis nigricans from gastric lung and uterine CA. So lastly, we have the clinical aspects of neoplasia. So yung causes of morbidity and mortality due to cancer. So first, you have your location and impingement on adjacent structures. So for example, meron kang brainstem glioma. So kapag lumaki yan, pwede niya ma-affect yung mga respiratory centers natin and you may die. And then you also have functional activities such as hormone synthesis or the development of paraneoplastic syndromes, bleeding and infections when the tumor ulcerates through adjacent surfaces. So for example, sa colorectal CA, pwede siya mag-ulcerate, pwede mag-bleed. Tapos yun yung presenting symptom niya, di ba? And then yung symptoms that result from rupture or infarction. And then lastly, you have cachexia or wasting. So pag napapansin nyo, yung mga cancer patients, pumapayat na sila and everything, it's because of the chronic inflammation from the cancer cells that produce TNF. So nagkakaroon sila ng weight loss, muscle loss, and overall mukha na talaga silang wasted. So that is all for basic pathologies. Thank you guys for listening. Good luck in clerkship or internship. And I applaud you guys kasi ngayon pa lang nagtitake na kayo ng steps to be prepared for boards. And no doubt in my mind, nakakayanin niyo yan. Just keep on going. Fight, fight, fight!
Hi guys, I'm Dr. Maria Inez Benedicto. I'll be discussing 4 chapters as part of Genesis Pathology. So first is infectious disease. So these are the histologic patterns of tissue reaction seen in infection. The first one is suppurative or purulent. So this pattern is characterized by increase in vascular permeability and increase in leukocyte infiltration, predominantly of neutrophils. This is in response to pyogenic or pus-forming organisms like your staph and strep. So the masses of these dying or dead neutrophils plus the necrosis of tissue forms pus. Okay, that's why pus, purulent, pyogenic organisms. The next pattern is mononuclear and granulomatous. When we say mononuclears, di ba, isa lang yung nucleus nila. This includes your lymphocytes and monocytes. So the presence of these mononuclears is a common feature of chronic inflammatory processes and also in response to viruses and some intracellular bacteria. Diba? Pag viral, lymphocytic, and lymphocyte is a mononuclear cell. Granulomatous inflammation is also another form of mononuclear inflammation, which is evoked by infections that resist eradication and are capable of stimulating a strong T-cell lymphocyte immunity. This includes tuberculosis. So, di ba nga, in TB, there is accumulation of macrophages. They become epithelioid cells, which fuse to form giant cells, and there is granuloma formation. That's why it's called granulomatous. The next reaction is cytopathic and cytoproliferative reaction. So this is usually seen in viral infections. So some viruses, they can replicate within the cells and they make these viral aggregates that are visible as inclusion bodies. So later on, i-discuss natin yung ibang mga inclusion bodies na yan, like your Cowdery type A na para sa HSV, ganon. Okay? Also, yung viruses, they also cause cytoproliferative reaction, cyto meaning cell, and proliferative meaning proliferation. Like yung nakikita natin, no, yung proliferation ng epithelial cells causing warts formation in HPV infection. Clostridium perfringens and other organisms like Cyanobacterium diphtheriae that secrete powerful toxins cause a pattern of tissue necrosis because this is the dominant pattern seen in this type of infection. Chronic inflammation and scarring is exemplified by hepatitis infection, which leads to scarring and cirrhosis of the liver. Meron din tayong no reaction, which is seen among individuals who are immunocompromised, okay, like in AIDS patients. So let's go to viral infections. So I divided it into 3: acute, latent, and transforming infection. Examples of acute infection are your mumps and measles. Your rubiola or your measles virus is a single-stranded RNA virus of the paramyxoviridae family. So it causes characteristic rash, Koplik spots, yung 3 Cs, yung cough, coryza, and conjunctivitis. So yung rash na nakikita natin in measles, it's brought about by the dilation of skin vessels and mononuclear perivascular infiltrate. Siyempre, viral infection to eh. So mononuclear or lymphocyte yung predominant na makikita natin. Yung Koplik spots, which is pathognomonic for measles, yung mga ulcerated mucosal lesion, di ba? Found near the opening of the Stenson's duct. So, meron din tayong tinatawag na Warthin Finkelday cells. So, these are giant multinucleated cells with eosinophilic inclusion seen in measles. So, ito yung itsura niya, Warthin Finkelday cells. So, meron siyang eosinophilic inclusion. Tapos, ito yung Koplik spots. Next is mumps. This is caused by rubella virus. Please remember this. This is very high yield because students tend to just remember yung pangalan na mumps virus. They forget about rubella virus na name. So this virus infects the salivary glands. It causes edema and inflammation, causing the classic presentation of mumps, which is salivary gland pain and swelling. So in parotitis, the gland is edematous, and again, yung infiltration na macrophages, lymphocytes, and plasma cells, mononuclears pa rin. Can also lead to orchitis or testicular swelling and encephalitis. Latency naman is defined as the persistence of the viral genomes in the cells of the body which do not produce the infectious virus. Yung mga latent infection na to, they can be reactivated and then cause infection na naman ulit. Latency is an important property of herpes virus, which are double-stranded DNA virus. Examples are your HSV 1 and 2, which causes the following disease. Gingival stomatitis, herpes around the mouth, is caused by HSV 1. Tapos yung genital herpes and neonatal herpes na din kasi diba dun lumalabas yung baby is caused by HSV 2. In terms of morphology, nagpa-present siya with large pink to purple intranuclear inclusions called your Cowdrey type A cells. Nag-fuse din yung cells nila and it produces this multinucleated syncytia. Next is varicella zoster virus, which is the cause of chickenpox and shingles or herpes zoster. So chickenpox, the rash occurs approximately 2 weeks after the initial respiratory infection, and then the lesions usually appear in multiple waves. Parang all types of lesions, makikita mo in chickenpox. They progress from macules to vesicles hanggang mag-crust na siya, and then mag-heal. Okay? Yung lesions sa chickenpox, tinatawag nila na dewdrop on a rose petal. So mamaya may picture ako niyan, pakita ko sa inyo. On microscopy, yung itsura ng vesicles, merong intraepithelial vesicles with intranuclear inclusion. Tapos, yung shingles mo, nag-occur siya if your VCV, which has remained latent in the dorsal root ganglia, is reactivated. Makikita mo to usually sa mga older individuals and doon sa may mga immunodeficiency. So, nagkakaroon ulit ng vesicular lesions, yung may mga shingles. And in contrast to chickenpox, yung lesions ngayon are more itchy, burning, and with sharp pain because may associated na siya na radiculoneuritis. And then we have cytomegalovirus. It causes disease depending on the host's age and immune status. Typically, it causes congenital and perinatal infection and mononucleosis-like infection. So, yung nangyayari naman sa mga cells infected with CMV is they become enlarged. Kaya nga yung pangalan, cytomegalovirus. Cytocell, mega kasi lumalaki sila. They also show cellular and nuclear pleomorphism, and there is prominent intranuclear basophilic inclusion. Yung tinatawag nating appearance is owl's eye inclusion. So, ito siya guys, Cowdrey type A, ito yung owl's eye appearance sa CMV, and ito yung dewdrop on a rose petal na rushes in chickenpox. So, Epstein-Barr virus causes infectious mononucleosis. This is a self-limited disease, but EBV can also cause several tumors like nasopharyngeal carcinoma and some lymphomas. So yung target ng EBV mo are the B lymphocytes because these are the cells that express the CD21 receptors. So characteristically, in EBV infection, the peripheral blood smear will show absolute lymphocytosis plus the appearance of atypical lymphocytes. Ito yung atypical lymphocytes mo, no? They are characterized by abundant cytoplasm. They contain multiple clear vacuolations. Tapos marami siyang scattered na azurophilic granules. So because this affects your lymphocytes, no, you can also expect changes doon sa mga lymphoid organs. For example, yung mga lymph nodes natin, lumalaki siya in EBV infection. And yung area na nag-expand is specifically yung paracortical area. Review nyo yung anatomy and histology nyo, no? Yung paracortex, yan yung area sa lymph nodes kung saan maraming T cells. Spleen is another lymphoid organ. It will also be enlarged and mag-expand yung white pulp, which is the region in the spleen which contains the lymphoid nodules. The liver is also usually involved up to some degree, and on examination, meron ka doon makikitang atypical lymphocytes. Next, we go to bacterial infection. We'll discuss staph and strep. So staph aureus is the cause of several skin lesions like abscess. Pwede din siya mag-cause ng sepsis, osteomyelitis, toxic shock syndrome, and food poisoning. So staph aureus causes pyogenic inflammation na may kasamang local destruction of host tissue. So because pyogenic yung inflammation niya, you can expect na ang findings usually predominated by polymorphonuclear cells or neutrophils. Also, yung staphylococcal scalded skin syndrome or yung Ritter's disease, initially, no, it looks like a sunburn rash. It spreads all over the body, it becomes bullae, and then it leads to skin loss. Important na i-remember nyo dito is that the site of desquamation in Ritter's disease is at the granulosa layer. This is in comparison doon sa site of desquamation sa toxic epidermolysis. Yung TEN syndrome, toxic epidermal necrolysis, yung desquamation, nag-o-occur siya doon sa epidermal-dermal junction. So remember that. Yung streptococcus mo, it also causes pyogenic infection. Yung skin infections niya, no, parang similar din sa staph aureus. However, yung tissue destruction dito is minimal compared doon sa staph aureus. One example of the skin infection is erysipelas. It has a sharp border, okay? And it's more superficial compared to your cellulitis. So ito lang, gusto ko lang to emphasize, cellulitis is a deeper infection, tapos hindi well-demarcated yung borders compared to erysipelas. Gram-negative bacteria, we have Bordetella pertussis, which is the cause of pink cough, okay? This is one of those bacterial infection na yung response ng body is lymphocytic. So remember that. We also have Pseudomonas aeruginosa, which is an important cause of pulmonary infections among cystic fibrosis patients, yung may mga burns, neutropenia, and also a cause of corneal keratitis and otitis externa. It has an important exotoxin A, okay? So yung morphology nito, it causes pneumonia in a fleur-de-lis pattern. It also causes coagulative necrosis, yung perivascular blue haze. Yung blue kasi, di ba, merong mga pigments pinoproduce yung Pseudomonas like your pyocyanin and pyoverdin. And also it causes ecthyma gangrenosum. So, Mycobacterium tuberculosis, so these are aerobic rods, di ba? Marami silang lipid sa cell wall nila. Kaya nagiging acid fast sila. Meaning, nare-retain nila yung stain kahit pa i-treat mo with acid alcohol. Okay? So, this Mycobacterium tuberculosis is the cause of TB. The source of transmission is usually from humans with active TB who release Mycobacterium in the sputum. Oropharyngeal and intestinal TB can also be contracted by drinking milk contaminated with Mycobacterium bovis. But right now, it is not common. So infection by Mycobacterium tuberculosis proceeds in several steps. The first is entry of MTB into your macrophage. They're able to do so because macrophage have these receptors, the CR3 and mannose binding lectin, as seen here in this figure. Second step, once they are already inside the macrophage, they will inhibit the maturation of the phagosome and they will block the formation of the phagolysosome. Therefore, they replicate within these vesicles protected from the microbicidal mechanism of the lysosomes. So, dadami lang sila ng dadami dito, eventually leading to bacteremia and seeding of the multiple sites. But despite of that initial bacteremia, most people are still asymptomatic. After about 3 weeks, a T helper subtype 1 response is mounted. So, kasi nga yung mga macrophage dito, they will be activated by the presence of interleukin 12 and interleukin 18. So, yung mga macrophage nito, magiging active sila, magiging bactericidal na sila. Okay? Yung T helper type 1 cells din na ito, they produce interferon gamma, which stimulates the maturation of the phagolysosome in the infected macrophages. They also induce the synthesis of nitric oxide synthase, which is important for the formation of intermediates to kill the mycobacteria. Yung Th1 response din na ito is important in granuloma formation because interferon gamma will cause these macrophages to differentiate into the epithelioid histiocytes, which will aggregate to form granuloma. Okay, so clinical tuberculosis is separated into two important types, primary and secondary TB. Primary TB, this occurs in a previously unsensitized individual. Usually, yung nai-inhale na bacilli, mag-i-implant siya doon sa distal air spaces at the lower part of the upper lobe or the upper part of the lower lobe. So as sensitization develops, an area of gray-white inflammation with consolidation develops. This is known as the gone focus. So this center, this focus, this will undergo caseous necrosis. Tapos yung tubercle bacilli, it can drain into the lymph nodes. So yung lymph nodes naman, maapektuhan, pwede din siyang mag-sheet. Okay? So this combination of gone focus plus lymph node is referred to as the gone complex. So in approximately 95% of cases, the cell-mediated immunity is able to control the infection. So there is healing by fibrosis or it can become latent TB. But in about 5%, clinically significant disease develops and becomes progressive. Tapos yung primary progressive TB mo, parang ano siya parang acute bacterial pneumonia lang yung presentation. Secondary TB naman is the pattern of disease that arises in a previously sensitized host. Pwede siyang mag-follow shortly after primary TB, pero usually it stems from reactivation of latent infection. So dito naman, it classically involves the apex of the upper lobes of both lungs. So lymph node involvement is not that prominent compared to the primary tuberculosis. But cavitation is common and it readily occurs in secondary TB. So this cavitation, they can erode into the airway, which becomes an important source of infection because now the cough, the sputum, meron na siyang Mycobacterium bacilli. Okay? So pwede din siyang mag-heal by fibrosis and pwede siyang maging progressive pulmonary TB. Yung progressive pulmonary TB, usually nangyayari to sa mga older adults and sa mga immunosuppressed individuals. So yung apical lesion, nag-e-expand siya into the adjacent lung, nag-e-erode siya doon sa bronchi sa vessels, and pag na-erode yung blood vessels, it may result to hemoptysis. Also, in progressive pulmonary TB, the pleural cavity is usually involved. So meron siyang effusion, empyema, okay? And then miliary TB, this happens kung nag-disseminate na yung tuberculosis mo. If it spreads via lymphatics, pwede siyang ma-expectorate ulit, causing miliary TB doon sa endobronchial, endotracheal, and laryngeal TB, and arterial spread para mag-cause ng systemic miliary TB. Tinawag siyang miliary TB kasi yung appearance niya parang millet seeds. And next, we have leprosy, also known as Hansen disease, which is a slowly progressive infection caused by Mycobacterium leprae. So there are two patterns of leprosy, the tuberculoid and lepromatous leprosy. In tuberculoid leprosy, intact yung cell-mediated immunity. Remember, cell-mediated immunity, sila yung sa delayed hypersensitivity. That's why nagkakaroon ka ng positive lepromin test dito sa tuberculoid leprosy. Also, yung bacilli are rare, kaya tinawag siyang paucibacillary. There is asymmetric peripheral nerve involvement. And in terms of morphology, yung granulomatous lesion niya resembles those seen in TB. In lepromatous leprosy, on the other hand, depressed yung cell-mediated immunity ng individual. So, hindi siya kayang mag-mount ng delayed hypersensitivity, nagiging negative yung lepromin test. Marami kang bacilli na makikita dito. That's why in terms of morphology, makakakita ka ng lipid-laden macrophages known as leprous cells, which is filled with acid bacilli, like this one. Ito yung mga acid-fast bacilli. Okay, next is syphilis. So this is caused by Treponema pallidum, which are gram-negative, slender, corkscrew-shaped bacteria with eggshell periplasmic flagella. So for all stages of syphilis, makakita ka ng proliferative or obliterative endarteritis, which usually affects the small vessels. So there are several stages of syphilis. Primary syphilis, this occurs 3 weeks after the initial infection. There will be appearance initially of a papule, which erodes into an ulcer, forming your hard chancre. So this is characteristically non-tender or painless. In terms of morphology, intense plasma cell infiltrate ang makikita mo. So, secondary syphilis naman, it occurs 2 to 10 weeks after the primary chancre occurs. So, in this stage, there is widespread mucocutaneous lesions, which involves the oral cavity, the palms of the hand, and soles of the feet. So, moist areas of the skin, like the anogenital region, they can develop broad-based elevated plaques called condylomata lata. There's also lymphadenopathy, mild fever, and malaise. And in tertiary syphilis, there are 3 main manifestations: cardiovascular, neurosyphilis, and the so-called benign tertiary syphilis, or the formation of gumas. So in cardiovascular syphilis, this accounts for 80% of the tertiary disease. There is endarteritis, or inflammation of the innermost layer of the blood vessels of the vasa vasorum of the proximal aorta, causing medial scarring and loss of elasticity. So nagkakaroon ng characteristic tree-bark appearance of aorta. Neurosyphilis, pwede siyang maging symptomatic or asymptomatic. We have tabes dorsalis, paresis, and meningovascular syphilis. Classically, makikita mo sa CSF findings, there is pleocytosis, high protein, decreased glucose, and positive VDRL test. Then we have your gumas, which can be seen on the bone, skin, and the mucous membrane. Okay, so congenital syphilis occurs most frequently during maternal primary and secondary syphilis because these are the stages where spirochetes are most numerous. So it affects several organs. We have syphilitic osteochondritis and periostitis. So these lesions are common, most especially in the nose. If there is collapse of the bridge of the nose, it can lead to this saddle nose deformity. And periostitis of the tibia, this leads to excessive growth of new bone on the anterior surface of the tibia, giving rise to saber shins. The liver and lungs can also be involved. And this is what I want you to remember, the Hutchinson triad. So interstitial keratitis, bulag, Hutchinson teeth, bungi, and 8th nerve deafness, bingi. Okay? So remember that. So there are 2 main types of serologic tests for syphilis. We have the non-treponemal and treponemal test. Non-treponemal tests, they are used as screening tests and to follow the efficacy of treatment. Treponemal tests naman, they are used as confirmatory tests. And ito naman, kahit pa i-treat mo yung patient, magiging positive pa rin itong treponemal test. So hindi siya used for following up treatment. In non-treponemal test, yung dinedetect dito is non-specific na antibody, yung reagent. in contrast to treponemal, na specific treponemal antibodies talaga yung dinedetect natin. So these are the examples for each type of test. Pwede nyong tandaan, no, lahat ng may R doon sa initial nila, those are non-treponemal tests. And then lahat naman ng may T sa initial nila, no, those are the treponemal tests. Yung exception lang sa rule is the trust, okay? So for both types of tests, highest sensitivity is seen during secondary syphilis. Next are fungal infections. So first, I want to emphasize on the difference of molds and yeast because this is high yield in the boards. Molds, they are multicellular, while yeast are unicellular. So these molds, no, they are made up of hyphae and they are filamentous in appearance. Ito siya, okay? Yung yeast mo, so ito siya, yung round or oval shape. Meron din tayong mga dimorphic fungi. They can transform from molds to yeast. So they become molds when exposed at room temperature and they become yeast when exposed at body temperature around 37 degrees. So probably one of the most important, no, fungi, Candida albicans. This is the most prevalent fungal pathogen of humans. This is a normal commensal of the skin, but it can become pathogenic, especially if there is immunocompromised state. So important dito, tandaan nyo, basta pseudohyphae, characteristic yan ng Candida albicans. Okay? Pseudohyphae siya kasi mukha siyang hyphae, pero hindi kasi it's just made up of budding yeast cells, okay, that are joined by constriction. So yung mga diseases na kinokos ng Candida albicans mo includes your oral thrush, esophagitis, vaginitis, cutaneous manifestation, as well as invasive infections causing abscesses. And we also have your pneumocystis jirovecii. So these are yeast-like fungus which causes a rapidly progressive bilateral pneumonia, particularly in AIDS patient. So ang itsura ng cyst ng pneumocystis, parang cup-shaped sila or oval with a central dot. So yung findings sa lungs, there is alveolar interstitial thickening and meron siyang eosinophilic honeycomb exudate in the lumen of the lungs, like this one. And lastly, we have parasitic infection. This is another favorite in the board exam, schistosomiasis. The most common species in the Philippines is Schistosoma chuponicum. Both Mansoni and chuponicum affects the liver and the gut, and hematobium affects the bladder. The infective stage to man is the cercaria. So these are the morphologic findings. In Schistosoma mansoni and chuponicum, there is initially a white pinhead size granuloma with schistosome egg at the center. Yung gusto kong tandaan nyo dito is that this can cause pipe stem fibrosis of the liver. So dahil nga may fibrosis, so nagkakaroon ka ng portal hypertension, giving rise to this manifestation, ascites, splenomegaly, and esophageal varices and ascites. And your schistosoma hematobium naman, so this preferentially affects the bladder. So there can be initially an inflammatory cystitis because of egg deposition. Later on, giving rise to the calcified bladder appearance on X-ray. And ito, importante ito guys ha, schistosoma hematobium is a risk factor for development of squamous cell carcinoma of the bladder. So ito yung pipe stem fibrosis. And then, ito rin, mayroon tayong miracidium containing eggs. Okay? So that ends the infectious disease. Next, environmental and nutritional diseases. So let's discuss first heavy metals. So lead is a readily absorbed metal. It binds to the sulfhydryl groups in proteins and it interferes with calcium metabolism. So lead exposure can be through the contaminated air, water, or food, but most of our exposure are from lead-containing house paint and gasoline. And in 2012, CDC has chosen 5 micrograms per deciliter as the reference interval at which clinical intervention should be taken to limit additional exposure to lead. So this is not the toxicologic threshold because there is no safe blood levels of lead. Also note here in this picture the different manifestation at certain levels of lead. As little as 10, there can already be decreased IQ, and as high as 150 can already lead to death. So ingested lead is very harmful to children because they absorb more than 50% of lead from the food compared to adults that absorb only about 15%. Most of this absorbed lead is taken up into the developing teeth, and there they stay for around 20 to 30 years. So excess lead is toxic to the nervous tissue. Among adults, peripheral neuropathies predominate, while central effects are more common in children because their blood-brain barrier is more permeable. So their brain is more susceptible to damage. So among adults with peripheral neuropathies, the extensor muscles of the wrist and fingers are often the first to be affected, causing wrist drop, followed by paralysis of the peroneal muscles, causing drop. So the effects of chronic lead exposure in children may be subtle. They can have low IQ and learning disabilities, but at the higher doses, it can lead to blindness, psychosis, seizures, coma, and even death. So these peripheral neuropathies in adults are usually reversible, while the PNS and CNS damage in children are irreversible. Lead also interferes with two enzymes in heme synthesis. The second enzyme in that pathway is the dehydratase, and the last enzyme in that pathway is ferrochelatase. Recall the action of your ferrochelatase. It is to incorporate iron into protoporphyrin to form your heme. So without that enzyme, meron kang protoporphyrin and iron na hindi nakakapag-combine. Yung protoporphyrin will manifest as high free protoporphyrin levels in the blood, and yung iron mo, nagkakaroon ka ng ringed sideroblasts dun sa bone marrow. So these are RBC precursors with iron in their mitochondria that can be seen if we stain it with Prussian blue. So you can suspect a diagnosis of lead poisoning in children with neurologic changes na mayroong microcytic hypochromic anemia with basophilic stippling in the RBCs. Tapos mataas pa yung levels ng kanilang RBC-free protoporphyrin. So lead will also affect other tissues like calcified cartilage and primary bone trabeculae, leading to the formation of these radiodense lead lines. Lead lines can also be seen in the mouth, no? This hyperpigmentation here, okay? Can also affect the GI tract in the form of lead colic, which is a severe, poorly localized abdominal pain. Tapos, kasi yung excretion of lead mo is by the way of the kidneys, it can also be damaged. There can be proximal tubular damage and saturnine gout because of the decrease in uric acid secretion. Next is mercury. So it also binds to the sulfhydryl groups in proteins. So there are three forms. Out of these three, the most important is organic mercury in the form of methyl mercury. Ito na kasi yung main source of exposure natin kasi from fish na nag-i-ingest ng mercury. So 90% of ingested mercury is absorbed in the GI tract. So we have Minamata disease, named after the city of Minamata in Japan. So ang nangyari kasi dito is nag-release ng methyl mercury doon sa Minamata Bay. So na-contaminate yung mga isda doon, tapos kinain ng mga tao. So among pregnant women, na-expose yung children nila in utero. So these children develop cerebral palsy, deafness, blindness, and other CNS defects. That's why now, pregnant women are advised to avoid consumption of fish known to contain high mercury levels. Can also damage the kidneys, leading to acute tubular necrosis, and chronic exposure can lead to nephrotic syndrome. So arsenic, it also interferes with several aspects of cellular metabolism. So it was used as an instrument of assassination among the royal families, kaya tinawag siyang poison of kings and king of poisons. So it's found naturally in the soil as well as in Chinese and Indian herbal medicine. So the most toxic forms of arsenic are the trivalent compounds listed here. So this toxicity may be attributed to the mechanism of action, which is interference with mitochondrial oxidative phosphorylation. So marami siyang effects, no, on the neurologic system. Pwede magkaroon ng sensory motor neuropathy. Cardiovascular, pwedeng magkaroon ng hypertension and prolonged QT interval. Sa skin naman, pwedeng magkaroon ng hyperpigmentation and hyperkeratosis, and then nakakakita tayo ng mist lines sa nails. So it also increases the risk of lung, bladder, and skin cancer. Yung skin cancer dito is different from that which is sun-induced kasi this is multiple and nag-a-appear siya sa palms and soles. And last heavy metal is cadmium. This is preferentially toxic to the kidneys and to the lungs. So yung sources of exposure is from mining, electroplating, and production of nickel-cadmium batteries. So the principal toxic effects sa lungs, obstructive lung disease, as well as an increased risk of cancer, renal tubular damage that may lead to ESRD, and then we have this itay-itay, which means ouch, ouch. So nangyari na naman to sa Japan because na-contaminate ng cadmium yung water used to irrigate the rice fields. So it affects the postmenopausal women, causing osteoporosis, osteomalacia, and renal disease. Next, tobacco and smoke. So smoking is the most readily preventable cause of death in humans. The risk of developing lung cancer is related to the number of pack years or cigarettes smoked per year. Importante din i-note natin that the use of tobacco products not only creates a personal risk, but also to the person who is exposed to the secondhand smoke. So maraming contents and chemicals itong cigarette smoke natin, 60 of which are identified carcinogens. One example of the contents is nicotine. So it binds to the nicotinic acetylcholine receptors in the brain, causes release of catecholamine responsible for the acute effects of smoking, like increase in heart rate and BP. Among pregnant women who smoke, they are also associated with preterm birth and stillbirth. So this is a table listing some of the important contents of tobacco smoke as well as their effects. So lang i-note, polycyclic aromatic hydrocarbons and nitrosamine, because they have been found to be directly involved in the development of lung cancer in humans. Other effects include an increased risk of cancer of the pancreas, esophagus, kidney, and bladder. So irritant din siya ng tracheobronchial mucosa, which may cause bronchitis, emphysema, and COPD. It is also linked to atherosclerosis and its complications like MI and stroke. And as mentioned, IUGR and stillbirth. Next is alcohol, which accounts for approximately 3.3 million deaths per year. So that's a lot. So this is a table summarizing some of the manifestations. At 80 milligrams per deciliter, this is the definition of drunk driving in most states in the US. At 200 milligrams per deciliter, drowsiness, 300 stupor. So nice to know din, yung amounts of alcohol exhaled in the breath is proportional to the blood levels. So this is the basis for the breath test in drunk driving. So most of the alcohol in the blood is metabolized to acetaldehyde by 3 enzyme systems: alcohol dehydrogenase, microsomal ethanol oxidizing system, and catalase. Yung pinaka-importante dito is this one, found in the cytosol. Your CYP450 is active in high alcohol levels, tapos yung catalase mo maliit lang, 5%. Okay? So some of the toxic products include acetaldehyde. So among Asians, about 50% of Asians, we have low aldehyde dehydrogenase activity. That's why parang some of us are unable to oxidize acetaldehyde and cannot tolerate alcohol. So this results to nausea, yung flushing, yung tinatawag nating Asian flush. Okay? Also, alcohol oxidation by alcohol dehydrogenase causes the reduction of your NAD to NADH. So among chronic alcoholics, mataas yung NADH nila, mababa yung NAD nila. Problema to kasi yung NAD natin is required for fatty acid oxidation and the conversion of lactate to pyruvate. So kung walang NAD, nag-accumulate lang yung fat kasi hindi siya na-oxidize, nagkakaroon ng fatty liver, and nagkakaroon din ng lactic acidosis. Metabolism can also lead to the generation of reactive oxygen species. Okay? So the effects of alcohol can be acute or chronic. So mainly sa CNS siya. It is a depressant, first affecting the subcortical structures, but at higher levels, it may depress the lower medullary centers, including the respiratory center, leading to respiratory arrest. Sa GIT and liver effects, they're usually reversible. So chronic alcoholism naman, yung main target is of course the liver. It can lead to alcoholic hepatitis and cirrhosis. So sa cirrhosis, magkakaroon ka ng portal hypertension, esophageal varices, and bleeding. Also, alcoholics are prone to thiamine or vitamin B1 deficiency, which may lead to Wernicke-Korsakoff syndrome. It's also a toxic product to the heart, which can lead to dilated cardiomyopathy, It's a cause of pancreatitis. It can also lead to certain cancers, okay? As well as fetal alcohol syndrome na mayroong characteristic appearance, microcephaly, and facial abnormalities. So itong itsura niya, okay? And lastly, we have environmental and nutritional diseases. Severe acute malnutrition was previously known as protein energy malnutrition, and it is defined as a weight for height ratio that is 3 standard deviations below normal. So at two ends of the SAM spectrum are kwashiorkor and marasmus. So kwashiorkor, this occurs if protein deprivation is greater than the total reduction in calories. So this is most commonly seen in African children na nawiwin too early and then finifeed ng exclusive carbohydrate diet. So walang protein. Nagkakaroon ng protein deprivation. Also sa kwashiorkor, there is marked deprivation or it affects the visceral compartment of proteins, which is found primarily in the liver. So this damage the liver, it leads to hypoalbuminemia. Kasi di ba liver is the site of albumin synthesis. Decrease in albumin, decrease in oncotic pressure, this leads to generalized or dependent edema. Yung weight ng mga batang may kwashiorkor is typically 60 to 80% of normal dahil namamas siya ng edema. Also, dahil may relative sparing of subcutaneous fat and muscle mass. So, yung nangyayari, nagiging enlarged and fatty yung liver kasi hindi napapalabas yung lipids in the form of apolipoproteins. Okay? Sa marasmus naman, no, this occurs if the child's diet is severely lacking in calories. So the weight falls to 60% of normal. And yung primary compartment affected is the somatic compartment, which is found in the skeletal muscles. So yung subcutaneous fat and muscles mo, ni-utilize siya ng body as source of fuel. Kaya nga yung mga batang may marasmus, mukha talaga silang payat or emaciated. Okay? The visceral compartment sa liver is not really affected, kaya yung albumin levels dito are normal or only slightly decreased. So, in kwashiorkor, no, meron din tayong characteristic na flaky paint skin, which is alternating sites of hypo and hyperpigmentation and desquamation. So, mukha siyang natatakta na pinta. Meron din tayong hair changes. Tapos, more common in kwashiorkor are also small bowel changes like mucosal atrophy and loss of villi and loss of enzymes. The bone marrow in both kwashiorkor and marasmus will appear hypoplastic because of a decrease in RBC precursors. So magkakaroon ka ng anemia. And dahil nga you have several deficiencies of multivitamins, you can expect nga there is immune deficiency and the child is prone to infections. So ito yung itsura ng batang may kwashiorkor, hindi sila mukhang payat kasi nga namamas siya ng edema. Ito yung flaky paint appearance ng skin, and ito naman yung child na may marasmus na payat talaga. And lastly, we have here anorexia and bulimia. So anorexia is self-induced starvation, which leads to marked weight loss, while bulimia is a condition where the patient binges on food and then induces vomiting. Anorexia has the highest death rate among psychiatric disorder. Tapos yung bulimia mo naman, although it is more common than anorexia, better naman yung prognosis niya. In anorexia, the effects on the endocrine system are prominent. Merong amenorrhea because of a decrease in GnRH and consequently a decrease in LH and FSH. There's also a decrease in thyroid hormone levels, which leads to manifestation of hypothyroidism like your bradycardia and cold intolerance and constipation. Dahil nga hindi ka kumakain, pwede kang maging dehydrated and magkaroon ng electrical disturbance. Pathognomonic finding din sa anorexia yung gelatinous transformation in the bone marrow. Also, the bone density decreases, possibly because of the decrease in estrogen kasi may problem ka sa endocrine. Okay? In bulimia naman, hindi masyadong payat, ganun kapayat yung mga pasyente. Weight is usually within normal and amenorrhea is found in less than 50% of patients. So in both your anorexia and bulimia, you can have dehydration and electrical disturbance, which predisposes the patient to cardiac arrhythmia and possibly death. Sa bulimia, dahil nga fino-force out ng patient na mag-vomit, pwede siyang magkaroon ng pulmonary aspiration or pwedeng mag-rupture yung esophagus. Okay? Factor diseases of infancy and childhood. Congenital anomalies, congenital means born with. So these are anatomic defects that are already present at birth, but for some, they may not be clinically apparent until years later, like your congenital heart disease and renal anomalies. So some definition of terms. When we say malformation, so these are primary errors of morphogenesis, meaning intrinsically abnormal talaga yung development ng certain organ na yun. Example, congenital heart defect and anencephaly. Next are disruptions. So these are secondary destruction of an organ or body region that was previously normal in development. So in contrast to your malformation, these are caused by extrinsic factors. Okay? Example, yung amniotic band syndrome. So yung amniotic bands, na-encircle niya or nako-compress yung the different parts ng fetus. Pwedeng mag-cause ng amputation, ganun. So these disruptions, they are not heritable. So they do not pose an increased risk in subsequent pregnancies. Next, deformation. So like your disruption, they're also caused by an extrinsic disturbance in the development. So this can be a localized or generalized compression of the growing fetus brought about by different biomechanical factors. It's primarily due to uterine constraint. Pwede yung may problem is yung sa mother, maliit yung uterus niya or may deformity yung uterus niya like bicornuate uterus, or pwede din yung problem is doon sa fetus like in multiple pregnancy. Okay? In sequence naman, it's a cascade of anomalies triggered by one initiating aberration. Example nito is your oligohydramnios or Potter sequence. So, oligohydramnios, it can result from a lot of things. Pwede due to amniotic leak, renal agenesis. So, decrease in amniotic fluid. This leads to the fetal compression. It may lead to pulmonary hypoplasia, yung characteristic fasciae na parang flattened yung mukha ng fetus, okay? Can also lead to positioning defects. And lastly, we have malformation syndrome, which is a constellation of congenital anomalies believed to be pathologically related, but in contrast to sequence, it cannot be explained on the basis of just a single localized initiating defect. Okay? So the exact cause of these anomalies remains unknown in majority of cases, 40 to 60%. So among genetic causes, chromosomal syndromes are associated with malformation. Example are your Down syndrome and yung mga iba pang trisomies. Environmental influences are also important. Example is rubella embryopathy. Remember natin yung mnemonics natin, no? Is eye, heart, ruby, earrings. Eye kasi meron tayong eye defects like cataract. Heart kasi meron mga cardiac anomalies like PDA. Ruby for rubella, and earrings kasi pwedeng magkaroon ng sensory neural hearing loss. Thalidomide, previously used as a tranquilizer in Europe, but it's associated with high incidence of limb malformation like phocomelia. Fetal alcohol syndrome, yung characteristic fasciae na discuss natin kanina, and in diabetic embryopathy, it may lead to fetal macrosomia, cardiac anomalies, neural tube defects, and other CNS malformation. So the timing of the exposure to the teratogenic insult is important. Between the 3rd and 9th weeks, the embryo is extremely susceptible to teratogens. The peak sensitivity is between the 4th and 5th week because during this period, the organs are being created out of the germ cell layers. But beyond 9 weeks, no, the susceptibility is greatly reduced. So next, prematurity. It's defined as a gestational age of less than 37 weeks. So this is the second most common cause of neonatal mortality behind only congenital anomalies. It has a lot of complications. What we will discuss today is RDS. So RDS, or hyaline membrane disease, because of the deposition of the characteristic hyaline proteinaceous material in the air spaces. So the incidence of RDS parallels with decreasing gestational age. 1% incidence at 37 weeks, then napakataas, 93% in 28 weeks and below. Bakit nga ba? Because with decreasing gestational age, so immature pa yung fetus, so there is also deficiency of surfactants. Okay? That is the fundamental defect of your RDS. Remember that surfactants are synthesized by type 2 alveolar cells, and they consist predominantly of your dipalmitoyl phosphatidylcholine, also known as lecithin, some amounts of phosphatidylglycerol, and surfactant-associated protein. So surfactants are important because they reduce the surface tension in the alveoli. So this reduced surface tension means decrease yung pressure required to keep the alveoli open. So it also prevents them from collapsing. So surfactant production is accelerated at the 35th week of gestation, and it is also affected by several hormones like cortisol and insulin. So yung mga condition na may mataas na intrauterine stress, so this will trigger cortisol production. So dito, mataas yung surfactant production, decreasing the risk of developing RDS. Surfactant synthesis naman is suppressed by high blood levels of insulin in infants of diabetic mothers. So insulin counteracts the effects of these steroids, and this may explain in part why infants of diabetic mothers have a higher risk of developing RDS. So this figure here shows what happens in RDS. Again, the fundamental defect is prematurity and surfactant deficiency. Without this surfactant, the alveoli will collapse, leading to atelectasis. So there is also reduced lung compliance. All this chain of events will lead to the production of a protein-rich exudate in the alveolar space, the hyaline membrane. Okay? Tapos yung hyaline membrane na to, this is additional barrier to gas exchange, causing further hypoxemia and carbon dioxide retention. So yung hypoxemia na to, it will further impair surfactant synthesis. So nagkakaroon tayo ng vicious cycle. So grossly, the lungs are of normal size. They appear solid, airless, purple, and they sink in water because there is absence of entrapped air. Microscopically, the alveoli are poorly developed, and those that are present are usually collapsed. Makakita din tayo dito sa arrows, no, merong mga eosinophilic hyaline membranes that line the respiratory bronchioles, alveolar ducts, and alveoli. On chest x-ray, makikita din yung characteristic na ground glass opacity. So let's now go to fetal hydrops. So this refers to accumulation of edema fluid in the fetus during intrauterine growth. So ito yung appearance niya, no? In the past, hemolytic anemia caused by Rh blood group incompatibility was the most common cause. Pero dahil nga successful na, meron na tayong mga prophylaxis, ngayon yung mas common na cause na are your non-immune eye drops. But what we will discuss today are the immune eye drops, okay? So these are hemolytic diseases caused by blood group antigen incompatibility between the mother and the fetus. So yung nangyayari dito, yung fetus, nag-i-inherit siya ng isang red cell antigen from the father, which is absent naman doon sa mother. So since wala yung mother ng antigen na yon, the mother will recognize it as foreign. So dahil foreign siya, magpo-produce yung mother ng antibodies that will attack those fetal antigens. So these antibodies, they can make their way through the placenta into the fetus and then cause the disease, okay? So let's compare RH and ABO incompatibility. Sa RH incompatibility, the case is that the mother is RH negative and the fetus is RH positive. So wala yung mother ng D antigen, so yung mom is magpo-produce ng anti-D. But on initial exposure sa RH incompatibility, usually hindi pa nagpo-produce agad-agad ng IgG antibodies yung mother. So usually it will produce pa sa subsequent pregnancy. That's why RH incompatibility usually manifests, okay, on second, third, and subsequent pregnancies. Tapos, yung antibodies dito are usually the IgG type. Remember, yung IgG mo, siya yung magkukross or nakakakross sa placenta. But now, meron tayong mga prophylaxis. We can give RH negative women rig or RH immunoglobulin at 28 weeks AOG and at 72 hours of delivery. Important to note din, no, concurrent ABO incompatibility can protect the mom against RH immunization because yung red cells ay nakukot na with antibodies, so hindi na siya nag-cross sa placenta, hindi na siya nakaka-trigger ng isoimmunization. And also, yung antibody response then, it depends on the dose of immunizing antigen. So in the case of RH, kailangan mga more than 1 ml no, of fetal RBCs yung makakross doon sa mom na circulation. ABO incompatibility, it's more common than your RH, but it is less severe. This happens if the mother is type O and then the baby is type A or type B. So, usually kasi, yung mga antibodies in ABO incompatibility are the IgM type. So, yung IgM type, hindi siya nakaka-cross ng placenta. So, yung hemolysis dito is not that severe. Okay? It can already manifest itself even on the first pregnancy. So, wala tayong prophylaxis for ABO incompatibility. But thankfully, no, hindi naman siya ganon ka-severe kung mag-manifest man siya. So, the two consequences are anemia and jaundice. So, dahil nga may hemolysis of RBCs, this can lead to anemia and can lead to hypoxic injury to both the liver and the heart. Sa liver, kung ma-injure siya, magde-decrease yung plasma protein synthesis. Sa heart naman, it may lead to cardiac decompensation and failure. So, the combination of this, decrease oncotic pressure at mataas na hydrostatic pressure will lead to the formation of edema. Kaya nga hydrops fetalis, parang may fluid accumulation doon sa fetus. Jaundice can also develop because hemolysis will release unconjugated bilirubin, which is lipid-soluble. It can cross the blood-brain barrier and lead to kernicterus. So, in terms of morphology, hindi naman sa lahat ng pagkakataon, no, severe and generalized yung hydrops fetalis. Pwede din isolated lang siya with just pleural or peritoneal fluid accumulation. Infants may be stillborn, they may die, but some naman they recover. Okay? So, if the hydrops is associated with fetal anemia, the fetus and placenta can appear pale, the liver and spleen are enlarged because of congestion, and the bone marrow demonstrates compensatory hyperplasia of the RBC precursors as a response to the anemia. Moreover, extramedullary hematopoiesis, meaning outside of the bone marrow, meron tayong mga RBC production, no, can occur in liver, spleen, and lymph nodes. Again, as a compensation. So, the increase in the number of immature RBCs in the peripheral blood, including mga nucleated RBCs, no, is called erythroblastosis fetalis. So, in kernicterus, the brain can appear enlarged, edematous, and when sectioned, pwede siyang magkaroon ng bright yellow color, especially in the basal ganglia. Next is cystic fibrosis. So this is the most common lethal genetic disease that affects Caucasians. So it is transmitted by autosomal recessive fashion, and the main defect is in the CFTR gene, leading to abnormal transport of chloride and bicarbonate. So yung function kasi ng CFTR mo is tissue-specific. Therefore, yung effect, magiging tissue-specific din. Okay, so ito, table comparison. Sa sweat glands, normally, yung CFTR mo, yung action niya is it causes reabsorption of sodium and chloride. So in cystic fibrosis, you can expect the opposite. Hindi na reabsorb yung sodium chloride, napapalabas sila sa sweat, kaya nagkakaroon ng hypertonic and salty sweat ang mga taong may cystic fibrosis. In the respiratory and GIT epithelium naman, CFTR acts by secretion of chloride. So in cystic fibrosis, again, hindi siya nakakasecrete ng chloride, meaning it just remains inside the cell or intracellular. So it creates electronegativity. So as a compensation for the electronegativity, magkakaroon ng increased sodium reabsorption. Again, where salt goes, water follows. So nagkakaroon din ng water reabsorption. So yung nangyayari ay nagiging dry or thick yung secretions doon sa lungs and sa GIT. So this is the reason, no, na prone sa infection and plugging yung mga organs na to. And in the pancreas naman, your CFTR regulates the transport of bicarbonate ions. So if defective siya, so walang bicarbonate doon sa pancreatic secretion, nagiging acidic siya, causing mucin precipitation and again, plugging of the pancreatic duct. So if it's plugged, di siya makakasecrete ng mga exocrine secretions niya, nagkakaroon tayo ng pancreatic insufficiency. So this picture just shows what I discussed a while ago. Normally, reabsorption in cystic fibrosis, hindi na reabsorb, naging salty yung sweat. Dito, normally, okay yung mucus no, sa cystic fibrosis dahil nagfa-follow siya sa sodium chloride, yung water nagiging dehydrated, yung mucus nagiging viscous. And protoplugging, okay? Clinical manifestations, again, because the pancreas is plugged, it can lead to pancreatic insufficiency, and these patients usually have fat-soluble vitamin deficiency. Meconium ileus can be seen in newborns. Liver, because of the plugging also, it can lead to chronic hepatic disease and focal biliary cirrhosis. Lungs, kasi nga dry yung mucus, so this is a fertile ground for infection, most especially by Staph aureus, Haemophilus influenzae, and Pseudomonas aeruginosa. There can also be congenital bilateral absence of the vas deferens and infertility and azoospermia. So ito naman yung mga morphologic findings, no? Again, there is plugging of the ducts, so you can expect atrophy of the pancreas, meconium ileus in the small intestine, stale plugging of the bile canalicula in the liver, leading to biliary cirrhosis in 1/3 of patients. In salivary glands naman, again, there can be dilatation of the ducts, eventually leading to atrophy and fibrosis. Sa lungs, maraming infection dito, and vas deferens. And lastly, we have tumors of infancy and childhood. Okay, we will discuss two. First is neuroblastoma. So this is derived from the neural crest cells of the sympathetic ganglia and adrenal medulla. This is the most common extracranial solid tumor of childhood. Okay, so majority are sporadic. So neuroblastoma, manifestation of large abdominal masses that usually crosses the midline. In younger patients, they may present with fever and weight loss. So neuroblastoma also metastasizes widely through the hematogenous and lymphatic system. That's why nakakita tayo ng proptosis and ecchymosis because there is spread to the periorbital region or yung tinatawag na raccoon eyes. Pwede ding magkaroon ng multiple cutaneous metastasis causing this deep blue discoloration of the skin, yung tinatawag na blueberry muffin baby. Kasi mukha siyang blueberry muffin. And then, pwede na magkaroon ng opsoclonus myoclonus, yung dancing eyes and dancing feet. So, in 90% also of neuroblastoma, there is elevated blood catecholamines and urine PMA and HbA levels. So, pwede siyang gawing diagnostic feature. So, majority of neuroblastoma are found in the adrenal medulla. Microscopically, so we have these small, primitive appearing cells with dark nuclei. Merong neuropil sa background. There can be formation of homerite pseudorosettes. So the presence of Schwannian stroma confers a favorable outcome. So Wilms tumor, on the other hand, is known as nephroblastoma kasi it's found in the kidney, okay? Nephro. This is the most common primary renal tumor of childhood and fourth most common pediatric malignancy in the US. Okay, so this is associated with 3 congenital malformation. The first one is the Weger syndrome, which confers 33% lifetime risk of developing Wilms tumor. So mnemonics to siya, no? W for Wilms, A for aniridia, genitourinary anomalies, tapos R kasi before it's called retardation. But now, the correct term to use is intellectual disability. At a much higher risk of developing Wilms tumor, around 90% are patients with Dennis-Rash syndrome. This is characterized by gonadal dysgenesis, early onset nephropathy, and gonadoblastoma. So they demonstrate a germline mutation or abnormalities in the WT1 protein. And lastly, there's also increased risk of developing Wilms tumor among patients with Beckwith-Wiedemann syndrome. So this is characterized by organomegaly, macroglossia, hemihypertrophy, omphalocele, and adrenal cytomegaly. So grossly, Wilms tumor are large, they are solitary, and usually these masses do not cross the midline. But if they're very large, some of them can cross naman actually. So yung composition nito, meron siyang triphasic combination of blastemal cells, consisting of small blue cells, epithelial component appears as abortive tubules or glomeruli, and yung stroma niya naman appears fibroblastic or myxoid. The presence of TP53 mutation, it signifies anaplasia and resistance to chemotherapy. So clinical presentation, again, abdominal mass that usually does not cross the midline. Pero kung nag-cross man siya sa midline, usually ma-differentiate mo siya from neuroblastoma. Kasi dito, mas common yung hematuria and hypertension. Okay? So this will be the last chapter that I will cover, blood vessels. So normally, your endothelial cells, they form simple squamous lining of the blood vessels. And in the normal state, they are usually non-thrombogenic in order to maintain the blood in a fluid state. They also act to modulate smooth muscle cell tone, and also they affect the growth of these smooth muscle cells. But in the face of certain stimuli, like the ones listed here, like turbulent flow, hypertension, cytokines, your endothelial cells can adjust their steady state. They can express new properties in a process called endothelial activation. So in this activated state, as shown here in the picture, they now express adhesion molecules, they secrete cytokines, and also nitric oxide for vasodilation and endothelin for vasoconstriction, as well as other growth factors. Endothelial dysfunction, on the other hand, is the alteration in the endothelial phenotype, transforming it into a pro-inflammatory and pro-thrombotic state. So this is responsible for the conditions like atherosclerosis and hypertension. So here, the smooth muscle cells are recruited. Diba, normally your smooth muscle cells are in the tunica media or in the middle layer here. So they are recruited into the intimal layer. There they proliferate. They produce extracellular matrix, leading to the thickening of the intimal layer. So since the intimal layer is here, so pag kumapal yan, yung mangyayari is magkakaroon ka ng obstruction to blood flow. Okay, so remember this because this is applicable to the diseases of blood vessels. First, hypertensive cardiovascular disease. So approximately 90% of hypertension is idiopathic, the so-called essential hypertension. But it is also thought that small changes in renal sodium homeostasis, the vessel wall tone or structure, as well as certain environmental factors act in combination to cause this essential hypertension. Okay? In 5 to 10% of the cases, the cause is known. In renovascular hypertension, such as in renal artery stenosis, because there is a block to the glomerular flow, this will induce renin secretion. So renin, in turn, acting via your RAAS, will cause an increase in blood volume, increase in vascular tone, causing increase in BP. Also, single gene disorders, especially enzymes involved in aldosterone metabolism, will increase aldosterone levels. So this leads to the action of aldosterone, which is salt and water reabsorption. So this increases blood volume and increases BP. In some patients, they may have a rapidly rising BP, which if left untreated can lead to death within 1 to 2 years. So this is called malignant hypertension, and it is characterized by severe BP elevations, systolic above 200 and diastolic above 120 mmHg. There's also renal failure, retinal hemorrhage, and exudates. So small vessel diseases are usually hypertension related. So in terms of morphology, there are two types. First is hyaline arteriolosclerosis. So arterioles here will show a homogeneous pink hyaline thickening, thus the name. So the position of this will cause associated narrowing of the lumen. obstructing blood flow. So this is found in the vessels of older individuals, whether they are hyper or normotensive, but it is more generalized among people with hypertension and diabetes. The next morphology is hyperplastic. So here, these lesions, they occur in severe hypertension. The appearance of the vessels here, they have a concentric laminated thickening of the walls, what we call the onion skinning, seen here in the image, no? So this will lead to luminal narrowing too. So these laminations or thickenings consist of your smooth muscle cells with a thickened and reduplicated basement membrane. So this is seen in cases of severe hypertension, malignant hypertension, but in malignant hypertension, meron pang fibrinoid necrosis and necrosis of the vessel wall. Next is atherosclerosis. So this underlies the pathology of coronary, cerebral, and peripheral vascular disease. There are two types of risk factors, non-modifiable, also known as constitutional risk factors, and the modifiable risk factors. So under the non-modifiable risk factors are genetic abnormalities and family history. Increasing age among those 40 to 60 years old, the incidence of myocardial infarction increases fivefold. Also, male sex is also associated with increased risk of atherosclerosis. Diba, in premenopausal women, they are relatively protected against atherosclerosis and MI. But after menopause, their risk increases and parallels that of men. Your modifiable risk factors include hyperlipidemia, especially if it involves increased LDL, hypertension, cigarette smoking, diabetes, and inflammation. So the figure here shows the sequence of events in the formation of plaques. So first, there is a reason for, there occurs endothelial injury and dysfunction. This can be due to hemodynamic disturbance when there is turbulent flow. That's why, di ba, yung mga plaques natin, they tend to occur at branching points of vessels because at branching points, dyan mayroong turbulent blood flow. Injury can also be secondary to hypercholesterolemia, especially if there is increase in your LDL and a decrease in your HDL. And also inflammation. So all of this injury, they cause increase in vascular permeability. They cause adhesion of leukocytes here. So yung nangyayari is nagkakaroon ka ng inflammatory process. Pagkatapos, kung mayroong chronic hyperlipidemia yung patient, yung mga lipoproteins, they tend to accumulate here in the intimal layer of the blood vessel. Tapos, since meron ng mga inflammatory cells dyan, like your macrophage, ginagawa nila is kinakain nila or ini-ingest nila yung lipoproteins and yung lipids. That's why nagpo-form sila ng foam cells. Foam cells yung tawag sa kanila kasi mukha silang foam dahil nga may na-ingest sila na lipid droplets. Tapos, yung mga modified na LDL na tuno, they also stimulate the release of growth factors and cytokines. So, it initiates a vicious cycle. So, kakapal ng kakapal yan with prolonged inflammation and everything. Also, your smooth muscle cells proliferate and they also deposit extracellular matrix, especially collagen. So, they deposit here and they transform the fatty streak into a plaque. So, the most common sites of involvement in descending order are the following. So in terms of morphology, the fatty streak are composed primarily of lipid-filled foamy macrophages. So they begin initially as small, flat, yellow macules that coalesce to form streaks, okay? So ito yung itsura, no? Kita nyo to, parang clearing, parang foam. Yan yung foam cells nyo kasi meron silang lipid droplets. And then as you can see here, no, yung fatty streak, they are not raised lesions, kaya hindi sila nagkakaroon ng problem sa blood flow. They will not obstruct blood flow. But with progressive intimal thickening and lipid accumulation, your fatty streaks can become atherosclerotic plaques, okay? So they are yellow-tan and they are raised above the vessel wall. So dahil nga raised na sila, they can now cause obstruction to blood flow. Your atherosclerotic plaques have four principal components. So as seen here in the picture, there is a superficial fibrous cup here, letter F, which is composed of smooth muscle cells and collagen. It stains blue because of the collagen content. Tapos, deep to this fibrous cap is the necrotic core, which contains lipid, primarily your cholesterol and cholesterol esters, as well as debris from dead cells, foam cells. Tapos, meron din tayong dito na mga more cellular area kung saan makikita natin yung mga smooth muscle cells, macrophages, and T lymphocytes. And later on, meron din siyang calcification. Okay? And also, manonotice nyo no, sa picture na to, usually, yung plaques is eccentric, okay? It does not involve the entire vessel. Usually parang patchy, one side lang, ganun, okay? So habang kumakapal to, it can lead to blood flow obstruction. So also, the plaques also undergo remodeling. The fibrous cup undergoes remodeling that can stabilize or can render this plaque more susceptible to rupture. Again, collagen is the major component of this cap and it accounts for mechanical stability. So those plaques with thick caps, they are called stable plaques. They are not prone to rupture as compared to your vulnerable plaques with thinner fibrogen caps and more prominent na lipid core. Okay. So consequences of atherosclerotic disease, they can either lead to stenosis as they gradually thicken and occlude the vessel lumen. So critical stenosis is the stage at which the occlusion is severe to cause tissue ischemia. This is typically happens if there is 70 to 75% decrease in the luminal cross-sectional area. So or also with this degree of stenosis, no, chest pain may develop with exertion, the so-called stable angina. Acute plaque rupture is the most dangerous consequence. So plaque erosion or rupture can lead to thrombosis, which can lead to acute coronary syndrome. So yung STEMI and NSTEMI. Next are aneurysms and dissection. So aneurysm is a localized abnormal dilatation of the blood vessel or in the heart. It may be congenital or acquired. So if it involves all the layers of an intact arterial wall, it is called a true aneurysm. In contrast, a false or a pseudoaneurysm is a defect in the vascular wall that can lead to an extravascular hematoma that freely communicates with the intravascular space. So aneurysms can occur when the structure and function of the connective tissue within the vascular wall is compromised. It can be seen in the following conditions. If the intrinsic quality of the vascular wall of the connective tissue is poor, like in Ehlers-Danlos syndrome, if there is abnormal transforming growth factor beta, as seen in Marfan syndrome, because there is problem in your fibrillin, so there is problem with the sequestration of your TGF beta. Can also be seen in cases of abnormal collagen remodeling and in cases when the vascular wall is weakened through the loss of smooth muscle cells, like in syphilis. So the most common cause of aneurysms in the abdominal aorta is atherosclerosis. In the ascending aorta, it's hypertension. So again, in abdominal aortic aneurysm, it's usually related to atherosclerosis, and it is usually found between the renal arteries and the bifurcation of the aorta. The typical patient is a male, smoker, and older than 50. So the risk of rupture is related to size. The bigger the aneurysm, the bigger the chance for rupture. Thoracic aortic aneurysms are most commonly associated with hypertension. So before there is dissection, yung usual symptoms ng mga taong may ganito are chest pain because of erosion into the bone, myocardial ischemia because of compression of a coronary artery. They can also have difficulty swallowing due to compression of esophagus, hoarseness because of compression of your RLN, and also respiratory complications. Yung pinaka-dreaded na complication no, is yung aortic dissection. This occurs when blood separates the laminar planes of the tunica media to form a blood-filled channel within the aortic wall. So major risk factor is hypertension. Tapos, it occurs principally in two groups of patients. The first one are men age 40 to 60 years old na may hypertension, and among younger patients na mayroong systemic disease like Marfan's. So the classic symptom of aortic dissection is a sudden onset of excruciating pain, usually beginning in the anterior chest, tapos nag-radiate siya towards the back, and then the patients feel like it's moving downward as the dissection progresses. Okay, so there are aortic dissection is classified into two types. The Stanford type A here, it is more common and more dangerous because these are proximal lesions that can involve either both the ascending and descending aorta or the ascending aorta only. So your Stanford type A corresponds to the Becky type 1 and type 2. In Stanford type B dissection, these are distal lesions which usually begin distal to the subclavian artery. So this is equivalent to the Becky type 3. Vasculitis is a general term for vessel wall inflammation with manifestations that will depend on the vascular bed that is affected. So these are the two mechanisms involved. So immune complex associated vasculitis can be seen in immunologic disorders like SLE, anti-neutrophilic cytoplasmic antibodies. These are ANCAs, no? These are autoantibodies that react against the constituents of the primary granules of neutrophils, but also found in granules of monocytes, lysosomes, and all. So these are the disease-associated anti-endothelial cell antibodies in Kawasaki disease and cell-mediated granulomatous lesions like in giant cell arteritis. So this is a table showing listing down the different conditions and the size of the vessels that are involved. So I will not really delve into them. Today, you will discuss this more when you go na to Top Notch Online. And finally, we have tumors. So hemangiomas, these are very common tumors and are composed of blood-filled vessels. They are usually present at birth. They can initially increase in size, but a lot of them spontaneously regress. Capillary hemangiomas are most common. They can occur in the skin, subcutaneous tissue, on the oral cavities, and in the lips. So histologically, they are composed of thin-walled capillaries with scant stroma. Cavernous hemangiomas, on the other hand, are composed of a large, dilated vascular channels, which are more infiltrative. And compared to capillary hemangiomas, they do not regress spontaneously. They can be locally destructive, but usually yung clinical significance nila is more on the cosmetic disfigurement. Okay, and also yung tendency nila to bleed. Okay, juvenile hemangiomas are the so-called strawberry type of hemangioma in newborn skin. They can be multiple. They usually grow in size during a few months, but then they regress by age 7 in most cases. And then we have pyogenic granulomas. So these are rapidly growing, red pedunculated lesions found in the skin, gingiva, and oral mucosa. So we have the granuloma gravidarum of pregnancy. No? They usually bleed easily and ulcerate. And finally, we have your Kaposi sarcoma. So this is a borderline or intermediate type of blood vessel tumor. So this is associated with infection by HHV8 and is usually associated with AIDS. Okay, it is more common in patients with AIDS, and it's usually used as a diagnostic criterion for diagnosis of AIDS. So it usually progresses through 3 stages: patch, plaque, and jewels. So this is the appearance: patch, plaque, jewels. Okay, so that's it. Thank you and see you again soon.